All right. So again, respiratory system, we're going to go into some more advanced concerns about respiratory, but if anything comes up in your mind about some of the concepts we've already reviewed, think asthma, think COPD, think pneumonia, because you may potentially see some questions on those topics also. Just a quick review of our respiratory system anatomy. It starts all the way up in the nasal area, sinus cavities. You have your upper airway. We've got our larynx and trachea bringing the vast majority of the air down into the lungs. We have the left lung and the right lung. Which one of those has one side has 2 lobes and one side has 3 lobes? Do we remember which is which?
Right side has 3 lobes.
Okay. And the right side, again, you can see that into the left lung, it's a much sharper turn from the trachea to the bronchi. Versus into the right lung, it's more of a slope. So from an aspiration pneumonia perspective, which side is more at risk to develop aspiration pneumonia?
I think we said the right side back in peds because of the anatomy of the bronchi.
That's right, John, because again, it's a straighter shot. If you aspirate something, meaning something was not supposed to, a foreign body was not supposed to go into the respiratory system, it's going to almost go straight down into the right lung. Why is aspiration pneumonia worse? I'll put it in quotation marks, but why is that more dangerous than other types of pneumonias?
Because it's also it's obstructive. There's something in there.
Well, it could be obstructive, so that, again, it could be a foreign body, but you're right in that it's often a substance that's not supposed to be in the lungs. You're not supposed to put food in the lung, even if it's a small amount. Even if it's emesis, like a liquid emesis, that's acidic. That's got old food particles in it. It's got bacteria from the mouth, which again, we've talked ad nauseum about how the bacteria in the mouth and GI tract are really some of the worst, if you will. So it really is a toxic foreign substance going into the lungs that creating that infection, which makes it that much harder and more to treat and more potentially toxic to the tissues as well. And then again, as you go all the way down, you have your alveoli where that gas transfer is supposed to take place. The oxygen is supposed to diffuse into the bloodstream, while the blood is supposed to release the carbon dioxide. And this is, we know, the 2 big processes of the respiratory system. There is the ventilatory, which is almost a mechanical process. That's the air getting in to the respiratory tract, down into the lungs, down into the alveoli. And then you have the circulatory perfusion process, where you need that the blood to come and pick up the oxygen and to release the carbon dioxide. So again, proper function of the respiratory system has those 2 diverse processes that both need to be optimal for optimal functioning. So again, that's exactly what this slide says. You've got the ventilation, which is sort of mechanical, and the perfusion to get the gases transferred. The other work of the lungs is to maintain acid-base balance. And the whole body is set up to maintain the pH of the body, of the blood, if you will. That's where it's optimal. And the lungs, the respiratory system could respond in a nanosecond to help compensate for changes in the pH. What's the other side of that system that maintains acid-base balance?
Urinary.
Yeah.
Kidneys, really. You know, sometimes when we say urinary, we're thinking of the mechanics of getting it out. But right, and it takes a little bit longer for the kidneys to respond to changes. But again, with lungs, you can potentially see changes all the time, very quickly, I should say. A little bit review of the anatomy. You are correct. Again, the right is larger. It's got 3 lobes. The left is a little smaller. It's got 2 lobes. And the whole pleural cavity is lined by this pleura, which is a really thick fibrous tissue that is within the ribs, contains the lungs, and helps. The pleura has this sort of sticky substance also that is supposed to helps keep everything inflated, if you will. Some of the diagnostic tests that we talk about when we're assessing lung function, respiratory function, is the chest x-ray. Sputum we can collect, although collecting a quality sputum sample is a skill unto itself. Again, we don't want something that's been sitting in the mouth particularly long. We want something good from deep within the respiratory system. So sometimes we will go in with a suction to try to get our best quality, fresh little bit of mucus, if you will. We do laryngoscopy and bronchoscopy, which is where small cameras are going down through the structures, visualizing what's happening within them. Angiography, since blood flow into the lungs is such critical to their function, being able to track that blood flow and looking for blockages at all is very important. A thoracentesis, does anybody remember what a thoracentesis is? So if you have fluid,
Yeah, I remember.
go ahead, tell me.
It's when you have fluid in the lung and they have to get it out, so they have to have you sit down and lean over something so they can basically poke a hole in your lung to let out the fluid.
Yeah.
Your lung
So,
doesn't collapse.
Real close, you described
In the
it.
pleural
It's the
cavity,
pleural,
right?
yeah, not the lung itself.
There you go. Right. It's outside of the lungs in most cases, in the pleural cavity. So that space between, which there's not supposed to be a lot of space between the pleura and the lung tissue. They're supposed to be sort of connected together, but we get a buildup of fluid for various reasons. And they can go in, as you said, with a needle, poke a hole through the chest wall and extract that fluid. That can be done from diagnostic perspective, and it can be done from a therapeutic perspective. Again, that fluid buildup in the pleura is potentially taking up valuable real estate. That's an area now where, because that pocket of fluid is there, the lung can't expand into. We know when lungs don't expand, we have increased incidence of atelectasis, which leads to increased instances of pneumonia. So again, it can be both diagnostic as well as therapeutic. Lung biopsies to check for tissue, particularly when tumors, nodules, and other things are seen, to see what's going on. A ventilation perfusion lung scan. And again, this is done when there's a perception that the blood flow is being blocked getting into the lungs for some reason, often a pulmonary embolism. Ventilation perfusion scans are also known as VQ scans. arterial blood gases. Again, those are, that's taking arterial blood, most typically from the radial artery, to check our acid-base balance. And then pulse oximetry. Every time you put a pulse ox on a patient, you are essentially assessing function of the lungs. So again, bronchoscopy, little camera goes down into the respiratory tract and can visualize what's going on there. These can be both, again, diagnostic and therapeutic. They've got little ones that can take biopsies of tissue. They've also got some with somewhat larger pinchers that can pull out foreign bodies, things like that. So if you're preparing a patient for bronchoscopy, they need to be nothing by mouth before the procedure, because the risk of aspiration, again, is very high. They will be, in most cases, sedated, conscious sedation, so that at least there's somewhat amnesia about the procedure. If they have taken a biopsy, if they've gone down and pulled out a foreign body, if they've done anything other than just look around, but even then, the risk for bleeding post-procedure is a very real risk. So again, you're checking vital signs. You are checking to see what their sputum looks like. You're trying to keep them comfortable and calm so that we don't increase the risk of bleeding post-procedure. And then other folks who are prone to bronchospasm, having a foreign object down into those tissues can perhaps increase the risk of bronchospasm and even pneumothorax. We are monitoring all vital signs post-procedure, both from a hemodynamic perspective in terms of heart rate and blood pressure, but also because of the risk of infection and all. Has anybody had a patient gone for bronchoscopy, or has anybody had experience with bronchoscopy?
I saw one in the spring in the OR.
Yeah?
Yeah,
And
it was kind of interesting. They didn't really wait though till they were really finished being put under. And I've actually heard this from a couple other people even this semester. And they really just like get the tube right in, some of the surgeons, I guess. And so the person's like half choking until it fully sedates them. But the visualization is super interesting to watch with them. And if you have somebody that explains it well, it's really helpful.
And it was probably done by a pulmonologist that, or an interventional radiologist. Those are the ones who typically do bronchoscopies, but I'm sure there are others who are qualified as well. It's unfortunate that you say that, because that they didn't wait for these folks to be full, under sedation, because the sedation works very quickly. I mean, we're usually talking a minute or two wait time here, or you haven't given enough sedation, and it's hard to believe that 2 to 3 minutes for patient comfort would make a difference. And of course, one of the medicines, as I said, is an amnesiac. So while the patient might not remember it, it just does seem short-sighted. But this is, again, a visualization of the camera going down through the mouth, through the trachea, and down into the bronchi. And depending on the size of the camera and the skill of the clinician, they can thread that through remarkably fine areas to really get a visualization. And you're right, Linda, there's nothing like having somebody explain what they're seeing. And once they orient you, the detail's quite remarkable. So again, we talked about thoracentesis, where again, whether it is diagnostic or therapeutic, what sort of diagnoses make you prone to pleural effusions, because that's what a thoracentesis is looking at, pleural effusions. That's what it's called when the fluid builds up in the pleura between the lungs. So what sort of diagnosis make people prone to pleural effusions?
Cancer.
Cancer, most definitely. Good answer.
COPD.
Could be people with COPD who progress to pretty significant right-sided heart failure. So could we take that one step further and just say folks with heart failure?
Yeah, I was gonna say congestive heart failure.
Yep.
Sometimes
Those folks
together
are,
with smokers.
Yeah.
They'll have both.
again,
Pulmonary
not
embolism?
this, what was that?
Pulmonary embolism.
I don't know what, I'm not sure about that one, Linda, pulmonary embolism and pleural effusion. That one I would have to look up. It wasn't on my list. I'm not saying no, I'm just saying I'm not aware of it. But the two that come to my mind most readily are the heart failure and oncology. And again, these are folks, and certainly you can have folks who get a pneumonia who end up with a pleural effusion. Those folks, it tends to be, when I say one and done, if they're a relatively healthy person with not a lot of pulmonary or cardiovascular long-standing issues, they might have a pleural effusion. They tap it, it resolves, and the patient goes on their way, if you will. But people with oncologically based pleural effusions or people with heart failure, they're prone to recurrent pleural effusions. And that's where the Pleurex and the Denver catheters come in. Again, ultrasound now has done a great job in making these much safer and more specific. You know, again, I remember the old days where you had everybody was tapping on somebody's chest trying to determine where did the fluid start, where did it stop. And so they had a chest x-ray, and then you went to physical exam and they tapped out and listened to the differences to decide where to insert the needle. Now they have an ultrasound machine that comes, identifies the puddle or the pool, if you will, and the needle goes in fairly straightforward. Sitting upright, some patients are laying down, but you want a calm patient. This is usually done with lidocaine and other anesthesia at the site. Not necessarily a systemic anesthesia, or sometimes we don't even do an anti-anxiety. We don't do conscious sedation for this. It's really just sort of lidocaine at the site to mask the needle stick so that they're still feeling pressure. Again, patient specific. If you've got somebody who's highly anxious, not going to be able to stay still, then an anti-anxiety might be important for them, but that's not necessarily standard. Even with ultrasound guided needle sticks, what do you think some of the risks are in a thoracentesis? What's a pneumothorax?
When you like prick the lung and it leads to air in the lung cavity.
Yep. So you prick the lung, and while you know our child, or at least my childhood vision of the lungs being big balloons is not true, you poke a hole in it, it does kind of deflate like a balloon. And so the lung area can deflate. That creates air in the pleural space. And again, less lung capacity. So we have to worry about pneumothorax post-procedure and bleeding also. Anytime you're introducing a sharp object into the body, we got to put bleeding on that table. And then removing the fluid from these effusions can be done with a vacuum bottle. They'll take samples of it. and collect the fluid. Now, I've talked of these Pleurex Denver caths. That's where once the needle is inserted, a tube with a valve is attached to the insertion site, and it gets taped to the patient so that on an as needed basis, this valve can be opened and fluid can be drained out of the pleural effusion. And that catheter will stay there until the patient doesn't need it anymore. And so the patient doesn't have to be restuck. It's certainly easier to drain when you know it's going to be a recurrent effusion, but the care of that catheter, again, we don't want it dislodged, we don't want it moving, we want to keep the insertion site clean, dry, and intact with a clean dressing that's air occlusive. We want to make sure it stays capped when it's not being used. We don't want to introduce any infectious source into the catheter or the tubing. But again, it does make it easier for patients who have recurring pleural effusions for them. So ventilation perfusion scans, again, I call this a VQ scan. This is looking at the blood flow through the lungs, and you are using a contrast to help identify that blood flow, and it looks for where are there blockages. And one of the most common kinds of blockages is a pulmonary embolism. And a VQ scan, it's graded on a probability. It's either, the report will either say it's a low probability or a high probability for a blockage. It's not overly definitive, if you will. We've talked about arterial blood gases, again, most typically out of the radial artery. If you're going to stick a big needle into the radial artery, which again, in most cases, if done by a skillful clinician, is a safe procedure. But you run the risk of a hematoma, you run the risk of arterial damage. How is the hand going to get arterial blood if you damage the radial artery? Is there any other artery that feeds the hand?
The ulnar.
The ulnar artery. It's not as robust as the radial, but it is there. And so before for when you progress to your nurse practitioner world, for those of you who have those interests, particularly acute care nurse practitioners, you do what's called an Allen test. You occlude the radial artery for I forget how long, and check the capillary refill of that hand to make sure the ulnar artery is sufficient to feed arterial blood to the hand. You don't really want to risk long-term damage to somebody's hand for the sake of a blood gas. The specimens, they're not going on ice anymore. In many cases, they're being tubed so quickly to the lab that they don't require ice anymore. But this is a sample that cannot sit around and wait. You draw an arterial blood gas, you get it down to the lab, whether somebody's running it down or whether your tube system is going to send it. Either way, make sure it gets off the floor on its way to the lab, because if it sits around, it's not valid. So here's a demonstration. Again, most hospitals, this is your APRNs, PAs, respiratory therapists more often are doing them nowadays, but it's fairly straightforward. Because of the need to do calculations relatively quickly with your blood gas results, and you know me, I don't tell you to memorize a lot, but you need to know your normals of your ABG values. I may give them to you if we have a quiz or a test so that you have a reference point, but these are really numbers that should be committed to memory. Pulse oximetry, again, we're looking for above 93 is considered normal most places. Many folks will talk about above 95, but again, the reality is Medicare doesn't pay for oxygen until they're below 90. And in a minute, I'll show you why. And when we talk about O2 sat, what are we actually measuring? Anybody know?
How much oxygen is being carried through the bloodstream? So
How-
it's perfusion,
Yep. And what's carrying that oxygen?
hemoglobin.
There you go. So it's how saturated the hemoglobins are. That's literally what the O2 sat monitors. And here's a quick graph of, so again, here's your O2 sat on the vertical axes. And now I get all technical, but you see here how the slope of the line is, it's almost quite flat from 100% to 95%, but you see how that slope really starts to increase once it hits about 90, 95. So that's where, again, anywhere between 90 to 100% in terms of how much oxygen is in the blood is fairly constant, but below 100, it decreases quite precipitously. How do we get patients additional oxygen? Well, pretty sure, has anyone not had a patient getting oxygen but via nasal cannula yet? Has everybody managed nasal prongs on a patient? So you know that what's from, and not about oxygen, I'm not even talking about respiratory assessment yet, but what's something you really need to check on a patient who's wearing nasal cannula?
If it's placed correctly and pressures along the ears and like cheeks.
Kevin, you're right. What are you worried about on the ears?
Pressure, like pressure sores or you know,
Exactly. Skin breakdown, exactly right. So you really need to watch for skin breakdown behind the ears. And although we don't see it on the cheeks much of adults, I'm sure we could, you will sometimes see it if they're too tight into the nares. And we certainly worry about it with the kids. That's sort of one of the reasons why, and again, I know not everybody saw this year, but when you put nasal cannula on children, we literally put a pad down, then the nasal cannula, and then we stick them down, stick the cannula to the pad, and we don't even always put it behind the ears because it's too much pressure. So we're really, you got to protect the skin when we're using nasal cannula.
Hey,
Yes.
another method is sometimes we would put it, instead of wrapping it behind the ears and down below the chin, just going from the nares straight back behind the back of the head and stitch it behind their head. Then you don't have any issue with the ears.
I agree with that, but then you got to watch the back of the head because you've got a big lump back there and it might not be comfortable for them. So just adjust the knot, if you will, or the slidey thing off to the side a little bit.
Yeah.
What would you call that slidey thing, James?
I call it a cinch.
Oh, cinch, that's good. Yeah, that works good. I won't remember that, but you're right. We typically don't run nasal cannula above 6 liters. Patients will tell you they feel like it's a hurricane blowing through their head, but you'll see it. 1 to 4 used to be more of the norm, but you will see it up to 5 or 6 short periods of time. And this is the most commonly seen oxygen at home via nasal cannula. Simple face mask, you can get up to a 60% concentration via a simple face mask. So if you need more oxygen than nasal cannula can provide, then face mask might be helpful. It's also better if you have somebody who is a true mouth breather. Nasal cannula might not be as effective. And again, with a face mask, you might get better coverage, if you will. But on the other hand, for some people, it's more anxiety producing also because they feel like it's covering their face. And it's kind of patient response. A partial rebreather, one of the differences between a simple face mask and a partial rebreather is the partial rebreather has a reservoir bag, so it's got a plastic bag connected to it. With a partial rebreather, you increase the amount of oxygen you can provide up to almost 90% concentration. And again, while you're giving this additional oxygen, this is still mixing with room air. So you're not able to provide consistently 100% oxygen concentration, even though that might be what's blowing through the source, if you will. And a non-rebreather also still has a reservoir bag, but it doesn't have holes in the face mask. So you really are getting the highest concentration without an artificial airway or mechanical ventilation using a non-rebreather. The Venturi mask, this does not have a reservoir bag, but I've talked about this before. When you open a Venturi set, it comes with different colored plastic valves, if you will, and each valve has the percentage marked on it. So you have to look at your order, 27%, 40%, 60%, and put the correct valve in to get the right percentage of oxygen. And then one of your jobs is to not lose those valves. So we usually keep them in the plastic bag and attach them to the O2 flow device so that we have them to change if necessary. And again, there's just some simple pictures of the different masks. When we're talking about mechanical ventilation, we start with CPAP, continuous positive airway pressure these days, which is, there's no artificial airway, it's non-invasive, but it is much more specific and a lot more settings to take into account. And so it's considered mechanical ventilation. This has been a real turning point in respiratory care because previous to this, you needed an artificial airway to provide mechanical ventilation. This is allowing patients to stay on general care units, not get an artificial airway, which has additional infection risks and all. So again, this is about pressure assisted ventilation. And oftentimes what the pressures do is mimic a physiologic function. When you breathe, your glottis closes and helps keep the oxygen in. When you're preparing to cough, the pressure builds up because the glottis is closing off. And these things help keep the lungs inflated, helps move mucus through, helps keep oxygen into the lungs. And if you increase these pressures, for patients who need it, you can increase the benefits and help support them through whatever diagnosis is going on. PEEP is peak end expiratory pressure, again, a physiologic pressure created in the lungs. And so while we call PEEP, 5% PEEP is physiologic, everybody with a functioning glottis should have 5% PEEP. CPAP can increase that to, again, keep the lungs open, improve oxygen delivery, and to avoid the need for an artificial airway. One of the most common uses of CPAP is for obstructive sleep apnea. So who remembers what obstructive sleep apnea is? Can somebody describe that to us?
It's when you stop breathing while you're sleeping. Like periods of yeah. I don't know. My dad has it. He wears this big machine.
Yeah. So what's stopping him from breathing in many cases with people with sleep apnea?
Is it the positioning, like being down?
Yeah, most often it's positioning. The airway, the trachea can almost collapse. That sounds more dramatic than it is. But what creates the snoring? There's a snoring is essentially a blockage somewhere in the upper airway. And sometimes it's because people who are obese have a greater incidence of sleep apnea because literally the weight of their chest is not keeping the airway open as much as it should. I mean, these are fairly soft cartilages. They're supposed to be firm and all, but you put enough weight on them, they'll sag a little bit. They lay down, they turn. There are other causes for sleep apnea also, but those are some of the most common. By increasing the pressure of the oxygen going in, that's just enough to keep the gas exchange within normal limits, which helps the patient in the long term. So again, snoring is one of the earliest risks for sleep apnea. And these folks, when they go for their sleep studies, show significant desaturations during these periods and all, which impacts your sleep, puts you at risk for stroke, puts you at risk for myocardial infarction, and additional weight gain, and the risks of lack of quality sleep is truly significant. BiPAP so with CPAP, it's usually if the patient can tolerate it, you only need to cover the nose, and it can be done with what they call pillows or a nose mask, whichever is more comfortable for the patient. But once we get to BiPAP, it's 2 levels of pressure, both inspiratory and expiratory. CPAP, it's just continuous pressure. But BiPAP will have both a different pressure setting for inspiratory and expiratory, and needs to be provided with a face mask that covers the nose and the mouth. So that's a somewhat, it might be more difficult for patients to get used to. Again, it's still, again, it says they're using nasal pillows here, so maybe they've developed, but I really think that the nasal pillows are used for CPAP only. But again, the patient needs to be breathing on their own. They need to have spontaneous breaths. This is just an external support to help them through the process. Again, either in your own family or have you had patients on CPAP in clinical or BiPAP in clinical. Sometimes they bring their own machines in if it was a planned admission.
I had a woman on CPAP on Monday,
Yeah.
but it's very new to her, and she's an incredibly anxious person, so she was very unhappy about it, and she kept describing that she felt really smothered by it, and it was causing her just extreme anxiety. So they were trying to work with her on that, but they were thinking about giving her an anti-anxiety medication in order to help her use it prior to bed.
And what did how was the pressure being developed when delivered, Linda? Did she have just a nose mask? Did she have the pillows? Did it cover her nose and her mouth?
It covered her nose and her mouth, but it was just the basic mask with the vents attached, but there was no pillows attached.
Yeah. So, and it's, and again, I don't know what the settings were. I'm not sure you know that at this stage either, but patients who can tolerate just the nose tend to do much better than those, especially if they're anxious and, as you said, they're feeling smothered. You can imagine that if something's over both your nose and your mouth, the sensation itself makes them feel like they're being smothered, despite the fact it's actually providing oxygen. And in many cases, especially for folks who have, I'm going to say, straightforward sleep apnea, it's just the pressure. It's room air that's being delivered. It's not hooked up to oxygen. It can be for patients that need it, but for most folks, they just need the pressures to keep the airways open for better ventilation. But it can be very tough for some folks to get used to. And I'm not surprised to hear they're thinking of offering her anti-anxiety meds. That's kind of how important fixing sleep apnea is, that you'll even consider anti-anxiety meds to prevent the problems that sleep apnea can cause. Do you understand what I mean? It's like adding anti-anxiety meds might seem like overkill to some, but that's how significant the problems are that develop with untreated sleep apnea. And then just, peak flow meters for our asthmatics. Again, this is the daily weight of asthma control. It puts the recognition of potential problem in the hands of the patient. So it's a great self-care issue, and we need to make sure we get good education to our patients about why they need to use their peak flow meters. So respiratory failure, and you'll see respiratory failure documented in your medical records. I won't say all the time, but it is one of those ubiquitous terms for folks with pulmonary problems that you see, and yet it is a somewhat nebulous term that doesn't have a specific meaning. What it essentially means is it's not enough oxygen coming into the body or not enough CO2 leaving the body. And what is causing it is what you need to get to the root of the cause to really figure out what's going on. Because respiratory failure, again, is a nebulous term that is too big. We need to figure out what the causes are. Could be mechanical, again, maybe it's the sleep apnea issue. Maybe it's a pleural effusion, something that's taking up valuable real estate in the pleural cavity. We know respiratory system is controlled in the brain. Is there something going on up there? Do we have a muscular problem, a neuromuscular problem, not coming from the brain per se, but impacting the nerves that are impacting the chest wall, if you will. And again, the blood gas is a really baseline assessment of that effective transfer of gases and the pH in the body. What are we looking for in a patient with respiratory failure? So dyspnea, problems with their pattern of breathing. Why is headache common in people with respiratory problems?
CO2.
That's exactly right, Eugene. Increased CO2 can cause a headache in people. So folks with poorly controlled sleep apnea will often report waking up in the morning with a headache. People who take a nap without their CPAP may report having a headache when they wake up. You're exactly right. Thank you. Restlessness, again, one of the very first signs of not enough oxygen is a subtle restlessness, perhaps a little increase in anxiety. So again, something that could be, your patient just came into the hospital, they weren't feeling well, they say they're anxious, and I'm not minimizing it because they probably are anxious. But let's do our respiratory assessment to make sure there's not something physiologically going on also. That restlessness can proceed to confusion, altered level of consciousness, tachycardia as the heart works harder to move more oxygen out because they're getting signals that there's not enough oxygen out there, hypertension over both short-term and long-term, dysrhythmias, alteration in the pattern of the heartbeat, decreased level of consciousness. So what was anxiety and restlessness and confusion descends to decreased level of consciousness, and then changes in the respiratory pattern, both the rate and the pattern, I should say, and then our adventitious breath sounds. We give oxygen, oftentimes, again, starting with nasal cannula and progressing as far up the chain as necessary to keep our oxygen saturations above 90, which is indicative of our partial pressure of oxygen levels of being 60 to 70%. It is much easier to breathe when you are sitting up, so we're going to keep them in Fowler's position. We are going to encourage them to breathe. They need to be intentional breathers. If possible, leaning forward, getting their back off the chair or off the back of the bed makes it easier to fully expand the chest wall. Bronchodilators, if they're appropriate, if you're hearing wheezes and things like that. And if we cannot improve our O2 sats and our blood gases with non-invasive oxygen sources, then we need to prepare for mechanical ventilation and ultimately an artificial airway to provide oxygen for folks. So acute respiratory distress syndrome, I think I said adult respiratory distress system before, I don't know why, or ARDS. So this is, again, this is one of those sort of complications of critical illness that you need to figure out what the source of the problem is and mitigate the source, because this is just, ARDS is a symptom more than a disease or a diagnosis itself. It's a confounding system. It can be difficult to treat, but you really need to provide supportive care for the ARDS while you're trying to find something curative to the underlying problem. And it is actually damage to the lung tissue. So it's changing that capillary permeability, and you get extra interstitial fluid. So it's not increased mucus. It's not, these folks might be coughing a little bit, but when you get interstitial fluid in the lungs, What do you hear when you listen to your lung sounds?
Crackles.
Crackles, exactly. But again, it's not heart failure that's causing the crackles, but it sounds like heart failure. But it's more diffuse. Remember heart failure crackles, the higher up they are, the more significant the heart failure, and it tends to be very positional, dependently positional. So if your patient's been sitting up for a while, you're going to hear them on both sides, maybe at the bases, maybe halfway up or so. If they've been laying down on one side, let's say they've been laying in bed and they've been on their right side, you go to listen to their lungs and maybe they're 2/3, 3/4 of the way up their right lung, but gosh, their left lung is clear. It's because from a dependent perspective, it sort of flowed down to where gravity is pulling it to. With ARDS, you have diffuse crackles throughout all fields. So again, thin interstitial fluid because of changes in the permeability of the tissues, and it really is indicative of damage to the lung tissue itself. I'm going to ignore that. So when you get an AB, so again, you have all this interstitial fluid. It's taking up valuable real estate for that transfer of gases. It's not as effective to try to move oxygen through the fluid, move the CO2 through the fluid. So you've got that sort of decreased transfer of gases, and your ABG is going to show respiratory acidosis, hypoxemia, and you're going to give increasing a percentage of oxygen, and it may or may not respond. So this is a significant big deal. Chest x-ray is going to show diffuse interstitial fluids. And again, the underlying cause is what you need to work on. Is it sepsis? Is it fluid overload? Is it shock going on? When you've got folks in different kinds of shock, this is how pulmonary failure starts in those patients and could be the beginning of multi-organ dysfunction. Different drugs, burns, DIC, all these things can also cause ARDS. And again, DIC we know is a function of something else also. Again, looking for the originating cause, if you will. These folks are very tachypnic. They're having a lot of trouble breathing. Decreased breath sounds with a lot of rales. ABGs well outside of the norms, hypoxemia that you cannot resolve even with high flow O2, high percentages of oxygen. And again, you're damaging the lung tissues, which is going to decrease. When we say pulmonary compliance, compliance is how much they stretch to let oxygen in. As those lung tissues get damaged, they get stiffer. And I think in the olden days, they said, well, just give oxygen with higher pressure, force it in there. That further damages lung tissue. So we said, oh, well, we can't be doing that. And they've had to find other ways to get oxygen down into the capillaries as best as possible.
Quick question.
Yes.
Was that why they were saying that there were some of the issues in the beginning of COVID with ventilating people and whatnot because their PaO2s were so low that venting them was actually causing more distress and increased risk of death?
That's one of the reasons, yes. They certainly, you know, most critical care and pulmonologists, critical care clinicians, pulmonologists, and I'm talking the nurses as well as, they've worked with ARDS a long time now. My understanding is that folks with COVID went into ARDS even faster than some other populations and other diagnoses.
Yeah, and that wasn't evident. Like people would be like up walkie-talkie, and then you'd take their PO2 and you'd be like, holy shnikes, they're like 40s and 50s.
Exactly. There was I read an article, I probably should have saved it and sent it to you, but I remember at the time, the reason I didn't was because I was like, oh cripes, we're all anxious enough. We don't need to be reading this article. Thank you very much. But the woman who did survive, she got out of the ICU. She was a runner. She every day she ran 5 miles. It was what she did. She got home, she did her 5 miles, the run went fine. An hour later, she literally couldn't catch her breath. And obviously she was scared. She's like, Chris, I need to go to the hospital. She went to the hospital. She was on a ventilator less than 2 hours later. And then spent something like 2 or 3 weeks in the ICU on a ventilator. And so, you know, you tell your story like, well, I just ran 5 miles and I felt really good. And then about an hour ago, I couldn't catch my breath. And most clinicians, I think prior to COVID would look at you like, okay, well, let's give her a little Valium, see what happens. We will check you for a PE. But that's how fast some of these COVID ARDS situations were evolving from literally beyond from exceptional functioning to critical illness. Does anybody have a different or better understanding or explanation for it? Because I do think some of these articles have been in the popular press more so than in the past. Okay, so let's see what else. So again, these are folks who with ARDS, again, they'll try CPAP to increase the amount of peak and expiratory pressure, but in most cases they do progress to needing an artificial airway and mechanical ventilation. When I say restrict fluid intake, yes, you want to keep these folks hydrated. You don't want to dehydrate them per se, but you also need to manage fluid balance very carefully. We keep them hydrated to the point where their blood pressure and their renal function is maintained, but we do not overhydrate. We've already got lungs flooded with interstitial fluid, so it's not usable, it's not part of the circulating, but adding excess fluid further complicates their clinical picture. Respiratory treatments, they are treated with usually low levels of diuretics, but again, you need to do a delicate balance because this is not heart failure related. You have to do it's a delicate balance using diuretics. Although in the article I posted from the American College of Cardiology, they call it the 3 Ps. Proning, so keeping them on their stomach a couple times a day for a period of time. Pruning, which is giving diuretics to keep them on the drier side, but maintaining blood pressure and renal function. And of course, at this minute, I can't remember what the other P is. It'll either come to me or I'll check it up in the next, what's it called, break. But so again, diuretics are part of the treatment of ARDS in many cases. Anticoagulants, again, we want to prevent blood clots for sure. And steroids. The use of steroids has been pretty common with ARDS through the years. There was some reports early days of COVID that steroids were not helping and they were concerned that they were actually hindering recovery. I believe my understanding is now that steroids have returned to the game plan for COVID based ARDS. And I'll tell you, this is sort of personal Carol Ann Wetmore concerns. You know, from the very beginning of my nursing school, I have looked to, and I think all my peers, everybody has looked to the CDC and the NIH for our guidance on anything new. They evaluate the research, they publish guidelines. I don't know what we would have done back in early HIV if we didn't have the NIH and the CDC to publish guidelines and current information. And if they published it, we believed it. It was being done with the highest level of integrity and standards. Again, this is personal, Carol Ann Wetmore speaking. I'm not sure I can say the same nowadays. So I'm not sure if I went to the CDC and pulled off their latest recommendations. Do I believe them the same way I did in 1989? Probably not a discussion for this class, but I need to tell you that that's sort of where I'm at. I'm not sure. Anyhow. All right, so patient is admitted to the emergency department with signs and symptoms that are suggestive of ARDS. What action should you, the nurse, prioritize?
Oxygen.
Well, by nasal cannula?
Probably not enough.
So the point of this one is recognize that your patient's going to require intubation. More than likely. This is a critically ill patient where really in-depth, timely assessment is critical, and they're probably going to need significant interventions. A pleural effusion, we already talked about thoracentesis as a diagnostic and treatment procedure. We talked about that's a buildup of fluid in the pleural space and all. Heart failure, cancer. Oh, you were right. Pulmonary embolism. I apologize. It's right here on my slide. Thank you. And then an inflammatory process in the body and trauma. So those are the some of the underlying reasons for pleural effusion. What does a pleural effusion look and or feel like to patients? Well, they may, they'll complain of pleuritic pain. So pleuritic pain is pain that is usually sharper with inspiration and increases with inspiration, but resolves a little bit with expiration. They may be more, you know, most people with respiratory problems are more comfortable at rest than they are with activity. This is a dry cough, if they have a cough sort of thing, might be a little tachycardic. Their CBC may show and may show signs of inflammation. So like a slight rise in white blood cells, that's where that slightly elevated temperature comes from as an inflammatory response. And again, you're when you're listening to lungs sounds, it's going to be, you're going to hear distant, faint, or decreased breath sounds near and over the effusion because of all that space and sound trying to travel through the liquid, the fluid in the pleural space. So you are going to have an alteration in breath sounds. They're going to be, though, decreased. You won't hear adventitious sounds necessarily there because it's not like ears traveling through the liquid as if it was pulmonary edema or increased mucus. It's just dull or distant or, and again, in most cases, it shows up on chest x-ray as well. There are two different kinds of fluids that build up. One is called a transudate. And so this is more common in cardiac failure. It's clear, pale when you get it. There aren't a lot of cells in it. This is really just sort of an excessy fluid that seeped out, if you will. And then there are exudates. This is usually a response to cancer or infection, tends to have a lot of cells in it, may have protein in it, cloudy. If it is, if the effusion itself is an infected effusion, it's called an empyema. That's where the effusion is essentially pus. So that collection of debris and white blood cells and all of that, that one of my favorite words in medicine. I love that, empyema. Great word. And again, that's more common with respiratory infections, cancer, or trauma as well. Obviously, astute respiratory assessment is absolutely critical. Have them sitting up, encourage deep breathing and coughing. What's our best way to encourage deep breathing and coughing?
You want to splint them with like a pillow or something.
And how do we make a game of it?
The incentive spirometer.
Incentive spirometer, exactly. Give them something that they can measure and count. Not only the splinting helps make them more comfortable. That's a great way to help them use it better to their advantage. But again, these patients should have an incentive spirometer at their bedside. They should be taught how to use it and encouraged to use it every hour or so. And again, you can anticipate a thoracentesis once the effusion is identified. For folks who have these, and this is sometimes more common with the heart failure based or the transudate pleural effusions, they may do a pleurodesis. So a pleurodesis is where they try to re-stick the pleura to the chest wall so that there's decreased space to reaccumulate fluid. And they can do it in a couple of different ways. They sometimes use a talc, it's done either in the OR or interventional radiology. They open a little spot and they can put in some talc powder, which increases the adhesions and adhesions are not usually good, but in this case it is, that the pleura will re-stick to the chest wall. They can also go in and create, I had a pulmonologist who said they literally run sandpaper over the chest wall, which creates a little bit of texture so that the pleura re-sticks to it as well. So again, there are a couple of different ways they can do that. All right, why don't we take a 15-minute or 11-minute break? Let's everybody come back at 10:15 and we'll pick up from here. Think if you have any questions, we'll pause. Okay. And now we're going to talk a little bit about airway management. So again, once we've exhausted all the non-invasive ways to increase O2 sat, gas exchange, etc., then we need to go with an artificial airway. And there are really two types. There's the endotracheal tube, which can go down either most commonly in the mouth, but the nose, past the larynx, or the tracheostomy, where a surgical stoma is created into the larynx, and it goes down again through the neck into the respiratory tract. Now, both of these are big infection risks. That's one of the biggest deals. They can be used with when there's an airway obstruction, such as either a tumor, if a patient's not able to breathe on their own, whether it's, again, mechanical or neurological. Mechanical ventilation can support that. High risk of aspiration, we can help with that as well. If a patient is unable to clear their own secretions, artificial airway can help that. And again, just general respiratory distress. So this is the, if you will, the anatomy of an endotracheal tube. The upper end that comes out of the body can be connected to a mechanical ventilator. Then it's a long white plastic tube that's has some subtleness to it. It does bend and all. It bends this way more than you can squeeze it. And then at the very bottom, there's what we call a cuff. It is a inflatable balloon that helps keep the tube in place. You inflate the balloon, and so first off, it closes the entire trachea, if you will, so that nothing can get by the balloon, but also it helps stabilize it and keep it in place by subtly applying pressure to the tracheal walls. And here again, there's a picture of, this is it deflated, so you see room within the trachea. Then this is with the balloon inflated, so there's subtle pressure against the tracheal walls, but it also occludes so that gas is only going in through the endotracheal tube. Means we need to keep the endotracheal tube clear, if you will. Again, it's probably more comfortable in the long run, and you can get the better / correct size tube orally versus nasally. And it can usually be gotten in, if not minutes, seconds with really skilled, easy intubators. You can use, again, a larger diameter that decreases the amount of work. You know, one breath will take in a larger volume of gas, if you will. You can even perform bronchoscopies via an endotracheal tube if the need be. You need to be careful, or I should say the folks performing the intubation need to be careful. You don't want to break teeth. You want to, if possible, survey the patient. Do they have any removable dental work? You want to remove that beforehand. And you may need to protect the endotracheal tube once it's placed. You don't want the patient to bite through it so that it becomes severed. And you also want to do meticulous mouth care once the tube is in. If you're doing a nasal intubation, it's more of, they do it blind. They can't actually visualize the vocal cords or the trachea, but that's often done when you cannot manipulate the head or the neck because of risks to the spinal cord. It's a smaller and longer tube that's used with nasal endotracheal intubation, which actually creates more work that needs to be done either by the ventilator or by the patient. When we talk about rapid sequence intubation, that means patient's going to be given a sedative and a paralytic very quickly. You're going to get the tube down, and the patient's going to be mechanically ventilated until either those medications wear off, or if they decide to continue those medications, which is sometimes common. By using the sedative and the paralytic agents, you decrease the risk of aspiration, which further decreases the risk of injury to the patients. We don't do that for cardiac arrest. We don't need to add those medicines to an already complicated scene. Or if they are not certain they are going to have a quick intubation, you cannot risk paralyzing someone unless you are relatively certain you can get an airway in. And obviously you need to monitor the patient very carefully hemodynamically and from an oxygen perspective. Patients who are going to be intubated, you need to hyperoxygenate them to the best of your ability before you start the intubation procedure. Now, this is tricky because one of the reasons you're intubating somebody is because you can't oxygenate them effectively. And so yet we're saying hyperoxygenate them if at all possible, because there's going to be some period, 30 seconds to a minute, where they're not going to be breathing on their own. But again, just monitoring the patient and doing your best to keep them safe is possible. Once you believe the airway is in the proper position, there are a couple of different ways to check placement, if you will. One is you can attach an end tidal CO2 monitor to the end of the tube, and that monitors, are we actually exhaling carbon dioxide, which is what we want coming out of the lungs. You listen to the lungs bilaterally, and on inspiration, do you hear breath sounds on both sides? That helps you tell, did we send it too far down the right side, so that it's down into the to the bronchi on the right side, and we need to pull it up before the carina, where the bronchi split right to left. That's called the corona. You want your ET tube to end before that so that you are equally ventilating both the right and the left lung. You want to listen over the stomach. It is possible that the endotracheal tube went down the what's the GI thing? Begins with an E. Esophagus. I got esophagus. It's possible you intubated the esophagus. So again, when on inspiration, you'll hear breath sounds in the stomach. You're in the wrong place. Pull the tube out, throw it out, start again, and then monitor the O2 saturation as well. So maintain, and then we'll ultimately get a chest x-ray. You will note, just like your PICC line or your nasogastric tube, we're going to note what measurement is at the lips. Going to document that so that when you start your assessment next shift tomorrow, whoever comes in, they can see that it's still at the same place. In most cases, you're going to connect it to oxygen, some oxygen source. You're going to secure it. You're going to tape it into place. You need to suction it periodically because there's no longer any glottis to create increased pressure for an effective cough. There is no cilia inside the ET tube to help move mucus up and out of the respiratory system, and you need to make sure they don't bite through the tube that does not help things also. Oops, sorry. Okay. How do you tape an endotracheal tube? Again, nowadays we use a lot of foam to prevent pressure ulcers. We use a fair bit of Velcro as well. But anyhow, it gets wrapped behind the neck, around the tube, over the lip. The other side comes, again, usually on top of the lip, then wrapped around the tube, and that keeps it in place. And that, just like with tracheostomy, trach ties, if this gets wet, if it gets saturated, if it gets dirty, it gets changed. And then you're going to, when I say change the position of the tube, if the tube was more on the left side, then the next time you change the ties, you change it to the right side. You're always being careful to assess for pressure damage to the tissues where the trach is placed coming out of the mouth. I think I spoke to all these. Yeah. Cutting off the excess tubing. So the tube comes, commonly, we used to call it the long white cigar. And you don't need to have 6-8 inches hanging out of the patient's mouth. It's just plastic. You can cut that tubing off so that it's sort of not too short, not close to the patient, not that close to the patient's mouth, but so that you don't have excess hanging down, getting caught in bed sheets and things like that. But everything else I think we talked about here. Correct tube placement is everything. You just like with a feeding tube, before you use it, you're using your endotracheal tube all the time, but you're assessing that placement a couple of times during your shift, and you are assessing their breath sounds for not just what do the breath sounds sound like, i.e. Are the rowels at the bases, or are they halfway up now? Are the wheezes getting better or getting worse? Do I still hear breath sounds throughout all lung fields? But you're also assessing it because you want to make sure the tube is still has correct placement, and that you are ventilating as much lung tissue as possible. Again, incorrect placement is an emergency. You have just sacrificed their airway. And so we need to make sure it's correctly placed. If it's not, it's an emergency. You call for help, and you bag, valve, mask, ventilate them with oxygen if necessary, until you reestablish an airway if they need it. We talked about the cuff. Again, it's oftentimes the respiratory therapist who's going to monitor the inflation pressure of the cuff, because again, those tracheal tissues are delicate. They are soft tissues. Excess pressure will create a pressure ulcer within the trachea itself. So we don't want them so inflated that you're causing a pressure ulcer. This is why endotracheal intubation is a temporary intervention. There is a lot of research that says 15 days or less. If you cannot remove the endotracheal tube within 15 days, they should go and have a tracheostomy placed, which is a long-term / permanent intervention, longer term or permanent intervention. But the risk of tissue damage to the trachea with long-term increases with the length of time a patient has an endotracheal tube placed. And we want to prevent those problems. But again, respiratory therapy often monitors these in the hospitals where we are working. And you want to make sure that you're using minimal volume, minimal pressure, while minimizing leaking around the cuff or the ET balloon, if you will. Again, a tracheostomy now can be a permanent intervention for some folks. Again, creates a stoma in the neck into the trachea, and then you can attach mechanical ventilators to the trachea or provide what they call blow-by oxygen if they don't need mechanical ventilation. This tracheostomies are performed if you cannot do an endotracheal intervention. Tracheostomy can be done emergently as well. And I think I've told you the story. I worked with a gal in the ED. She was the best. Donna was the best. She has a wicked peanut allergy, to the point where she has, if it's a brand she doesn't recognize, she basically doesn't touch it. If she's going out on a date, there, like the date is under, she developed a list of things that they cannot eat for 3 days prior to their date, because she won't make out with somebody if they've had these foods in the last 3 days. And she came into work. There was a package of cookies with a brand that she recognized. This is when we were working in the ED. And she used to work in the PD ED. And again, this is the old ED at Yale New Haven. So the PD corridor was on the other side of the triage desk. Then there were double doors to get into the main part of the AB section. And so from the PD corridor nurses station to the trauma room, we're talking about 25 yards, not talking a long distance. There was a package of cookies of a brand that she recognized. She went in to take a cookie, and the way she tells the story is she thinks the package knocked her hand. She immediately started getting red and hives. She turned, and somebody had put other cookies in the package, and she didn't realize that earlier. She turned, started walking right past trauma, and she got to the door of the trauma room. I should say, she walked past triage to the trauma room. She collapsed there, was already an O2 sat in the 50s or 60s, couldn't articulate anything. We lifted her up, put her on the trauma bed, called anesthesia, called a code. Everybody knew about her allergy, started giving her epi. I got an IV on one side. I forget who got the IV on the other side. Anesthesia came running down to try to intubate her. They tried 5 or 6 times to intubate her. They literally had the scalpel at her neck to do an emergency trach, and anesthesia slid the ET tube in. But in the course of less than 5 minutes, she was already so difficult to intubate, they were moving right to tracheostomy. So when you cannot cannulize the trachea, you try a tracheostomy. It's just a shorter distance, if you will. Long story, but always one of my memorable ones. So bypassing obstruction to get an open airway. It is actually easier for a patient to remove secretions, to mobilize secretions with a tracheostomy. And then you also have what they call less, quote unquote, dead space. A tracheostomy tube is made, and I'm going to use inches because I'm terrible at estimated centimeters, but a tracheostomy tube in an adult patient is really about 6 inches long versus an endotracheal tube, which is probably about 8 to 10 inches or so by the time you get through the mouth and all. And that plastic or metal, because some trach tubes are metal, that's called dead space. Nothing physiologic happens within the plastic or the metal. And just by decreasing the amount of plastic or metal, you improve the physiology of respiratory function. I know that that's a complicating thought, but it really does play a role, particularly while you're trying to get patients back to breathing on their own. So again, when you're looking at long-term artificial airway, like a prolonged comatose patient, tracheostomy is the way to go. A patient with cancer of the larynx or the neck with a high risk of obstruction because of tumor, trach is a great option. Patients unable to swallow may also do well with a trach. Burn patients, COPD patients, again, long-term mechanical ventilation and minimizing the amount of dead space. We get a lot of PD patients with congenital issues or premature issues who need to wait for their lungs to grow into them, into their size and function, do well with trachs for prolonged periods of time. And then neurologic patients, whether it's ALS or plegic patients, trach again because of the ability to be a long-term intervention. So your trach again is a surgical stoma into the neck through the trachea. Again, we call these trach ties or strap to hold it into place. And again, so this is a good way to visualize on the left-hand side. Here's the trach coming through the stoma and still has the same balloon or inflatable cuff, if you will. But look how much longer an endotracheal tube would be if it was coming through the mouth down to the essentially similar placement. And again, all that extra plastic is just nothing physiologic happens there. And that, as I said, becomes a problem in the long term. So again, after either trach or an ET tube placement, secretions may increase, so we need to keep that airway clear. We need to, patients, although it's not truly a cough in the physiologic sense, but a huff may help move secretions through the plastic tube, but suctioning them will help keep it the most clean. And again, a well done trach has a well-fitted stoma around the tube and usually has minimal bleeding, but it is a surgical procedure and the risk of bleeding is still there, so we need to do frequent assessments for that. And we, again, assess the inflammation at the site. Again, mostly to prevent infection or to recognize infection over time. Subcutaneous emphysema is where oxygen gets into the soft tissues. That's certainly part of a side effect of the surgery related to the tracheostomy. And subcutaneous emphysema feels like Rice Krispies under the skin, little beads that can have some movement sort of thing. You want to keep that trach in place. You don't want to manipulate it overly much because that just further damages the tissues. And like many first surgical dressings, oftentimes it's the physician who will do the first tube change. And so again, comparing the size and lengths really. The size meaning they come in Frenches. That's the like your indwelling catheters is measured by French, but the length of the tubing, whether it's a trach or an endotracheal tube, is very different. For a trach with an inflatable cuff, there's a balloon outside. This looks just the same thing as for an endotracheal tube. And again, it is often initially the respiratory therapist who monitors the pressure in the balloon. And the trach comes with a couple of different parts. There's an inner cannula, which can get changed more frequently. There's an outer cannula, which can have the inflatable cuff. And there's an obturator, which is a hard, stiff probe that for inserting initially the trach is helpful to keep it from bending. It sort of directs the tube in. And they're all curved like this as well. So the outer cannula is a big deal to change. It does get changed on occasion, oftentimes with by the prescriptive clinicians. The inner cannulas get changed a couple of times a day. So you need to know if your patient has a trach, is it a disposable setup, or do we need to clean the pieces and not throw them away? Obviously, if it's a metal trach, it's not disposable. You remove the inner cannula, you scrub it with sterile saline. There's usually a trach brush. It looks like a bottle brush, so you scrub out all the mucus and sputum that have dried on it. You pour normal saline over it to get it, sterile normal saline, to wash away anything you've used, any debris or anything, and then you replace the cannula, the inner cannula in to the trach. If it's disposable, you remove the inner cannula, it gets thrown away, and a new one gets placed in. But it's important, especially when you do a trach change, you get to see this is not a particular, I don't want it in me. It looks like it would be uncomfortable, but most of these trach tubes are kind of like the width of your finger, your pinky, if you will. That's not overly large. You put a little bit of mucus or some dried sputum in there, you've really decreased the width of that cannula. So keeping it clean is very important. And that's what a trach change is all about. They use cuffless tubes in pediatrics a fair bit, again, to prevent tissue damage. And also it means you can have a larger diameter of the tube, but you also need to have patients who are not at an aspiration risk. Over time, if this is going to be a long-term solution, we want patients to be able to talk. So they may put in a fenestrated trach. A fenestrated trach has holes or fenestrations above the cuff, which allows airflow over the vocal cords, which allows patients to talk. So they regain their voice and their ability to speak for themselves. That's usually a great day. Even with a fenestrated trach, they also attach a Passy-Muir valve to facilitate talking. Some patients need to relearn how to talk with a trach, and there are other folks, once they get either the fenestrated trach or the passing Muir valve, just start talking and never stop again. It's great. But again, working with your speech therapists can really improve the patient's quality of life once they regain that ability to talk. So again, the obturator is that hard, stiff, that's really only used when the whole entire trach is being placed. And sometimes they put it in when it's being removed. If you see one at a bedside, don't throw it out. But I don't think I could not remember ever looking for an obturator for any purposes. The flanges are on the outside of the inner cannula, and that's what you attach your trach ties to. See those little indentations there? You can put your trach ties to them. And then there's the cannula itself. Again, cuff inflation is important to prevent tissue damage and to prevent aspiration. Anytime we're monitoring somebody with an artificial airway, we want to make sure their O2 sat is maintained. We're always assessing for signs of hypoxemia. Blood gases, if they're in an acute situation, blood gases are done more often. But if they are into the chronic long-term stage, blood gases are not necessarily critical on an ongoing basis with a stable patient. And then we talk about the signs of hypoxemia again, changes in mental status. What starts as a little restlessness, a little anxiety can progress to confusion, to decreased level of consciousness. Skin color, respiratory rate, all your hemodynamics need to be assessed on a regular basis. We get our PCO2 monitoring from our blood gases. They can also put a end-tidal CO2 monitor. Those are increasingly common in the ICUs. The work of breathing, that use of accessory muscles, if they're still having trouble, even with an artificial airway. And then again, the rate and the rhythm of the respiratory effort. So while we're completely committed to keeping the artificial airway clean and with decreased mucus, routinely suctioning a patient increases the risk for tissue damage and potentials for infection. So you really need to watch your patient and listen for signs of increased mucus. If they are coughing or huffing, then we probably want to suction them. If you've got signs of bronchi bilaterally and they were juicy, if you will, beforehand, we want to suction them. If the ventilator is alarming high pressure alarms, well, first thing you do is check to make sure a tube isn't kinked, because that will create a high pressure alarm. But it could also be because there is mucus building up and they need suctioning. And again, if the O2 sats are going down, maybe suctioning might help improve that situation. Nowadays, we're using closed suction techniques almost exclusively for suctioning because the risk of ventilator-associated pneumonia is so significant. It decreases your risk of exposure to secretions. It decreases the amount of time that the system is open to risk for contamination. And here's a picture of that. So here's your patient with your endotracheal tube. Your mechanical ventilator tubings are set up. And right here is a closed suction setup. So there's a suction catheter. It's surrounded by a plastic sleeve like a plastic bag. And here is your suction control, which has an on and an off. You twist it to turn it on, you twist it to turn it off. If you are not suctioning your patient, and this is whether they've got an endotracheal tube or a trach tube in, you need to turn this suction control off. All you need is for a patient to roll over, compress this suction button because it wasn't turned off, and now even if they're on oxygen, it's being sucked out because we didn't turn this control button off. So if you're not suctioning, turn that button off. When it's time to suction, you shimmy that catheter down, intermittently suction to bring it out. In kids, you continuously suction. In adults, we usually intermittently suction. Give the patient a chance to rest. You can go down for a second pass to see if you get more mucus. Usually 2 passes are my maximum, so make them count. Most ventilators now, certainly the ones we use in the hospital, have a button that you push to suction. It hyperoxygenates the patient. It puts the alarm on hold and gives you 2 minutes to complete your 2 passes to suction, which should be, with enough practice, more than enough time. So the ventilator does an alarm, they're hyperoxygenated, you get your suctioning done, and you move on your merry way. But this is a closed suction setup that's been shown to be effective to decrease ventilator-acquired pneumonias. Here are the complications of suctions. Again, hypoxemia, you're sucking out oxygen. Bronchospasm, if you go down too far and start touching the tissue down there, you can create bronchospasm. If the patient is coughing, if you're increasing that pressure, it's almost a Valsalva maneuver, which we know increases intracranial pressure. With hypoxemia, potentially comes dysrhythmia, blood pressure changes, tissue, mucosal damage. I'm talking about damage to the tracheal bronchial tissues themselves. If you poke too hard, go too deep, bleeding, pain, and infection are all risks of poorly done suctioning. So we hyperoxygenate before and after suctioning. Again, most ventilators nowadays have that button that you push that facilitate that. You need to become pretty quick, less than 10 seconds. 2 passes, 3 at the most, and watch your O2 sats before, during, and after suctioning. The suction catheters are obviously connected to your wall suction, and you don't want to use a vigorous suction. It really is fairly light suction. And so you want to look at your wall suction to make sure that when you're compressing the suction button or when you've obliterated the suction tube, make sure it's still less than 120 millimeters of mercury. And you don't want to aggressively poke at lung tissue that just causes damage, bronchospasm, potential bleeding, and things like that. Patients have thick secretions. We want to keep them hydrated. We can humidify the air that's coming through the O2 source. We no longer use saline to loosen secretions. That's been shown to, again, increase the rate of pneumonias. And then mobilizing your patients with artificial airways. Even though certainly with a trach, but even a patient with an endotracheal tube in can get out of bed and sit up a couple of times a day. This is where for sure it takes a village to mobilize these patients. It's not a one-person show, but it is good for the patient to get out of bed, for sure. Mouth care with an endotracheal tube or even tracheostomy is critically important. Their mouth is always open. The tube is there. They cannot close their lips. Their mouths get dry. Secretions crust both on the lips, the teeth, the lung. So we need to do aggressive mouth care on a regular basis. We brush their teeth. Or some oral swabs use hydrogen peroxide. The chlorhexidine oral rinse has been shown to be critically important in preventing ventilator-associated pneumonias. Lip balm, not Vaseline because it's a petroleum-based product, although Vaseline is often the only thing you can find in the hospital. But keep those lips moist, keep them free from crusting and mucus and secretions all dried up. They can still have the lemon glycerin swabs. Just try to keep the mucosa moist and keep it clean. You can suction the back of the throat. You can suction the mouth cavity. And again, repositioning the endotracheal tube from side to side to help prevent pressure sores is critically important. Being intubated is it's a psychologically stressful scenario. It's also physiologically stressing to the patient. There's increased anxiety. You need to figure out a way to communicate with these folks. If they're alert, you need to use judicious use of sedatives and figure out a way how to keep these patients relaxed. I could not imagine not being able to talk. That would be god awful for me. What's a sign that a patient's ET tube is in trouble? Well, unplanned extubation. When a patient starts talking to you and they've got an artificial airway in, that's usually a sign that something's not right. A low pressure alarm. It is a lot easier to blow air into the surroundings than down a respiratory tract. So you will have a low pressure alarm sometimes if it's misplaced. You're not going to hear breath sounds when the airway gets displaced. They'll show signs of respiratory distress. And again, if it ends up in the GI tract, you're going to have gastric distension. How do we prevent extubation? Well, we keep the ET tube secured properly. You need to keep track of all your tubes, hands, and the head as you're repositioning your patients. It's not unusual to use sedation, paralytics, and analgesia while a patient is sedated. Getting rid of the tube as soon as physiologically possible helps an unplanned extubation also. So using standardized weaning protocols where assessments are done by the nurses on a daily basis, that respiratory therapy and nursing work together to exercise the patient so that they're ready for extubation as soon as possible. And we definitely use wrist restraints and mitts as needed to keep prying hands away from all tubes, not just the endotracheal tube. If your patient is unplanned extubation, stay with them, call for help, use your bag valve mask bamboo bag to ventilate them and to provide psychological support, sometimes for you as well as for the patient. Your mechanical ventilators have a whole slew of settings that need to be determined in your orders before you know what's going on. How much air is going to be pushed into the lungs with every breath? That's part of the order. That's called the tidal volume. How often is the machine going to breathe for your patients? That's the rate part of your orders. Every single person has a physiologic sigh. You're probably, we sigh from an emotional perspective as well, but physiologically, from a respiratory neuro perspective, we sigh every once in a while. So again, sighs are built into mechanical ventilation. What percent oxygen is going to be delivered? Well, we know long-term exposure to high percentage pure oxygen is damaging to lung tissue. So you want to use a percent oxygen as low as possible while maintaining your O2 sats. Again, part of your orders. How much pressure is the mechanical ventilator going to use to push a breath in? Continuous positive airway pressure. How much pressure is it going to use so that all of it doesn't escape on exhalation? That's PEEP, positive end expiratory pressure. So again, FiO2, CPAP, PEEP, pressure support, all part of your orders when you get to that point in the ICU. And then when you're looking to remove the ventilator, how do we get the patient back? We have to wean down these settings. Well, maybe we don't breathe as often for the patient. Let them breathe on their own more and more. Well, maybe they started out at 70% O2. Remember, 100% O2 via nasal cannula or mask is one thing. But when mechanical ventilator down an artificial airway, you're delivering pure oxygen down there. So we need to decrease that O2 percentage. Maybe they were at 70%. Well, we're going to get them down to 60, 40% through the weaning process. Take more of the pressures away. So again, that physiologically the lungs are doing more on their own. I think I just described all this stuff. The ventilator can also be set to different, what we call modes. It's really determined by patient needs, neurological as well as respiratory wise. And sort of the modes are a science unto itself. Again, part of the orders once you get to that place. So again, your respiratory assessment needs to be frequent and thorough. You're looking for changes. You want to know your patient's baseline, then how is it progressing over time? You need to know your ventilator settings. That's really important. You need to, in most cases, air is totally humidified nowadays. Very rarely is dry air forced into a system. Like all alarms, you need to listen to them. You don't ignore them. You check on them. Why is it alarming? It's usually not capricious, so we need to check that. High pressure, low pressure, could be low tidal volume, again, that they just couldn't force the whole amount in, or wow, it was really easy and it got that whole amount in. And then there's the whole thing that the ventilator's not working, or if it was not plugged in, the battery is low. But again, no alarm goes ignored. You need to check each alarm and confirm that it's resolved. Tiffany, you had a brief discussion with your preceptor this week about alarms. Remember, Kate went into that patient, they were turning her, there were a bunch in, it was saying low volume, and they said, oh, she probably just breathed with the machine, and they rolled her over, and in fact, the ventilator had come disconnected from the endotracheal tube. So it was, again, not capricious. It's not that she just was breathing with, which made it too easy for the ventilator. She had become disconnected from the ventilator. So you really need to be hyper aware of this stuff. Never turn the alarms off. We talked about that in PD as well. And again, anytime you're on the unit, I'm sure you hear all the alarms. They all have a different sound and they need to be checked. I haven't had too many mechanical failures, thank goodness. But again, disconnect the machine, ventilate with your bag, your Ambu bag, and call for help. Position your patients the same as whether they're on a ventilator or not. They're at the same risks for skin breakdown and pressure sores. They need to turn in position because of all of the hazards of immobility that we've talked about since January. You need to try to figure out why a ventilator is alarming. Again, if it's a high pressure alarm, increased secretions, bronchospasm, is there a tube kink? Low pressure alarm, is it disconnected? Or is the patient breathing with the ventilator, or have they stopped breathing? Any of those things are possible. So when you first put a patient on a ventilator, you need to be aware of what their blood gases are. They were probably extremely abnormal when they went on the ventilator, and we need to make sure we are in fact in the process of correcting their blood gases. We worry about, especially if pressures are very high, you worry about pneumothorax or subcutaneous emphysema, are risks of mechanical ventilation. We talked about how stressful this is on the GI system. So patients should be on a PPI prophylaxis, as should all hospitalized patients often. If you have an endotracheal tube in, you cannot feed by mouth. We need to figure out a way how to feed that patient via the GI tract as soon as possible. We need to prevent infections. We need to combat muscular deconditioning and all those other, again, hazards of immobility. And we do not want patients to become ventilator dependent if at all possible. And particularly with COPD patients, if it's not done correctly, ventilator dependence is sort of a risk, and that adds a whole nother layer of complications to transition planning. So again, weaning is about decreasing ventilator support. We want the patient to take over the responsibility for breathing as soon as possible. And again, it takes a team to get a patient off a ventilator for sure. And it starts with the machine doing as much work. And again, we decrease the percent oxygen, decrease the number of times the ventilator breathes, Have the patient breathe on their own. You can even do trials. Maybe they're doing very well during the day when they're alert and oriented, and they can just use blow-by oxygen, connect just oxygen to either the endotracheal or the trach tube. Maybe when they sleep, whether it's a nap or at night, they need to be put on the ventilator. That's not uncommon, particularly for people with neuromuscular disorders. That when they're alert, they can do a better job controlling their respiratory function. But once they go to sleep, that ability to impact it decreases. When you're getting ready to remove the endotracheal tube, again, obviously there's a team there, but the patient's hyperoxygenated. You suction them before you remove it. You have to decrease the cuff if there's a cuff, and then you have them take a deep breath, and just when they're taking that deep breath, almost finished, you pull that tube out, and again, encourage them to deep breathe and cough as necessary, and they often need, again, supplemental oxygen after the tube is removed. And then very careful monitoring after the post-extubation. You don't want them to get a mucus plug, so they can need to continue to deep breathe. We don't want to see increased work of breathing. We don't want them to get tired. We need to watch their O2 sats. They may get a blood gas if they're concerned about pH and CO2 retention. So again, careful assessment after extubation is critical. So we talked about with patients with ARDS in particular, and this has become a huge issue with COVID, but the advantages of putting a patient face down on their stomach in the prone position, it moves fluid around in the lungs. It makes it easier for the chest to expand. The pressure is now on the sternum rather than the back of the respiratory field, and it takes it used to take, and actually I know for a fact the hospitals that instituted prone teams during COVID, it was a 6-person team that went to each bedside to turn the patient with the nurse who was caring for that patient. So it is a resource, a human resource intensive therapy, but is absolutely critical to ARDS management for sure. ECMO is another high-tech intervention for folks who need pulmonary and cardiac support. It's almost I'd say bedside, but it is a way to take blood out of the body, oxygenate it, and put it back into the body so that you're almost bypassing the respiratory tract to improve oxygenation. It's not completely unlike a pulmonary bypass machine used for open heart surgery. But in this case, the patient's heart is fully engaged doing its work, and it's just a matter of taking the blood out of the body, oxygenating it, and getting it back. There are lots of centers that do ECMO to support oxygenation for patients. When we talk about positive pressure ventilation, that's really any mechanical ventilation with PEEP or pressure support, things like that. You run the risk of decreased cardiac output because you're increasing thoracic pressure, which then therefore also changes the pressure in the pericardial cavity, which decreases cardiac output. If the pressures are too high, you have barotrauma of the lungs, which leads to scarring and fibrous tissue development of the lung tissue, which has long-term sequelae, that scarring and fibro lung development typically does not resolve over time. So these folks have long-term respiratory problems. When we get hypoventilation, we end up with atelectasis. And this is true whether a patient is sitting in their chair and they're not deep breathing, whether it's because of pain or decreased mobility, or you put them on a ventilator and their tidal volume isn't significant and you're not fully ventilating. You end up with atelectasis and the increased risk of pneumonia as well. You change that thoracic pressure, you have increased distress and coughing, you increase your intracranial pressure, which again can potentially have neurological impact. The risk for stress ulcers and subsequent GI bleeding increases. And then your musculoskeletal impacts, loss of muscle strength, risk of DVTs, pressure ulcers, all of the hazards of immobility. And then the big one, ventilator-acquired, ventilator-associated pneumonias. This is one of those publicly reported, I don't actually, let me scratch that. I don't know if it's publicly reported anymore, but I certainly know that within critical care areas, this is a measure of quality that they take very seriously. And one of the cool things is it's actually surprisingly easy to prevent. And it's all nursing interventions that prevent ventilator-associated pneumonia. So you worry about contamination, poor hand washing, the cough function that's decreased. And some of this comes through the actual intubation process itself. And though if you can mitigate these factors, you prevent VAP through the process of intubation itself. But the longer that artificial airway is in, you still have risk of ventilator-associated pneumonia. So what do we do to prevent it? Keep the head of bed elevated at least 30 degrees. Peptic ulcer prophylaxis, that's that PPI, prevent stress ulcers, prevent GI bleeding. Oral care is the #1 most important. Effective oral care is incredibly important to preventing ventilator-associated pneumonias. So again, doing it using the chlorhexidine rinses a couple times a day, critical. Embolism prophylaxis, that's your, whether it's heparin or Lovenox subcutaneously, we want to prevent DVTs and we want to prevent pulmonary embolisms. And then assess and manage pain, do breathing trials for readiness for weaning, choose your analgesia and sedation carefully, do a sedation holiday regularly to assess level of consciousness and the patient's ability to participate in breathing and respiratory function. Get them mobilized. Again, getting a patient out of bed when they're intubated, attached to a ventilator, is a hassle. It's not something you're doing alone, but it's critical. And then keep the family involved also. And these are all different ways to prevent complications of not only VAP, but of intubation itself. Again, this is a huge stressor for patients, between not being able to communicate easily. You're in the ICU, which we talked about from a sleep disorder potential. It's a high risk environment. what happens to patients when they get sleep deprived? What's that D word? To their mental status?
Depression?
Delirium?
Delirium was what I was looking for, but depression is a good one also. So you need to, assess, and even in patients who are, sedated or paralyzed, again, you still need to talk to them. You still need to touch them. You need to assume they are fully competent, fully aware, and fully alert. It's so important. We use paralysis on occasion, especially if a patient is particularly anxious and restless and is what we call bucking the ventilator. Let's give them a bit of a chance to let the ventilator do its job to help improve their blood gases. Maybe that will help their mental status also. But you got to remember, if a patient's paralyzed, so now they've got a machine doing their breathing for them, but paralysis itself, they can still think, hear, and feel. But now they've got the additional terror that they can't move. So you have to use sedation in analgesia. And when I say sedation, I'm talking about an amnesiac as well, while you use a paralytic. The less they remember, I suspect, the better off they'll be. But that doesn't change how we approach those patients in terms of believing that they can still hear, see, feel what we're doing to them. So we need to build a trust with them that's critical. Being ventilated actually increases your metabolism despite the immobility. So we need to make sure that they are adequately being fed. We need to make sure, usually we work with the nutrition experts on the unit, figure out how to feed them. It's oftentimes through a feeding tube, which of course we need to assess placement. And on a regular basis. You actually limit carbohydrates to folks with respiratory complications because that can decrease carbon dioxide production. I think the most important thing there is just a balanced diet. Patients they need adequate calories in a balanced manner. But there have been some studies that show increased carbohydrates can increase carbon dioxide production as well. We want to make sure they're getting adequate protein. That's critical to maintain intact skin and to heal any wounds they may have. Low albumins, low total proteins, no healing. So again, balanced, all things being equal, if you don't have other concerns in terms of liver or kidneys, you just want a balanced diet for these folks, and you can't let it go too long. And if they've been extubated and now they have their mouth back, you still need to do a swallow study before you feed them by mouth. We need to make sure their gag reflex is intact and they're not going to aspirate. All right, this one's done, kids. Why don't we come back at 11:45 and we'll do the next one? Any questions? Any stories? Anything somebody wants to talk about? Yeah, the heck with you. I'll see you at 11:45, okay?
Okay, Carol Ann.
Okay.
All right. So more about the respiratory system. Dun-dun-dun. All right. Another area of problem that can come, folks with healthy lungs, but some sort of trauma, whether it's a blunt trauma or a penetrating trauma, can cause damage to the lungs. And so how do you care for patients with these sorts of injuries? is an issue also. And blunt trauma, I think I had this conversation. I don't remember whether it was in class or somewhere else, but you know, you're moseying down the highway in a vehicle, you're wearing your seat restraint, and you stop dead. Think of it as a crash. Your body and your internal organs are going to continuing moving forward until your seat restraint stops you. But again, your internal organs are going to keep moving until they hit the hard chest wall. This can create contusions and bruising internally. That's got, again, it seems like the seat restraint is a good thing, and it clearly is. Don't misunderstand me. But there are still risks for injury, even if you're wearing your seat restraint. Externally, some of these injuries look relatively minor. Again, somebody may come in with really significant hematomas related to the seat restraints or whatever they hit, but you have to be concerned about internal organ damage as well. And they're often worse on the side of the body where the body actually stops. So in the case of the seat restraint, it's going to be on the front side of the body. If somebody fell backwards and landed on the ground, perhaps the damage would be more significant on the dorsal side of the body, if you will. You can have rib fractures that can lacerate a lung. You have particularly high velocity impacts. You can get shearing forces that can tear an aorta. These are not uncommon injuries that you're going to see in a trauma room at any point in time. Your penetrating injuries, you know, we think of gunshots, we think of knives, other sharp objects. We had a young kid come in. This was not a respiratory issue, but he had a typical old-fashioned flexible flyer wooden snow sled going down the hill. Whether he hit a rock, hit something, that was, you know, up for debate. Anyhow, the sled kind of came apart, and when it splintered, he had a piece of wood through his leg, his upper thigh, that we were real concerned about his femoral artery, his femur in general, and all those soft tissues. So penetrating injuries can be quite memorable and aren't just always your knife and gun club related things. Then we also have the flail chest. Is that the next thing? The flail chest. A flail chest is when you have a fracture of 2 or more ribs in 2 places, so that a portion of the ribs are essentially floating, not connected to the sternum or the spinal column. And again, the ribs are supposed to provide structure. So with these floating portions of the ribs, you get some really interesting movements. I'm going to try to no, of course not. So escape. Give me a minute. I just want to show you this. Control, click. Now, did your screen change, or are you still seeing the PowerPoint?
We're still seeing the PowerPoint.
Okay, give me a minute. I know how to change this. So this was clearly in an emergency room somewhere. But I want you to look on, when I restart the video, look on this side. So when he inhales, you see the chest wall move out, and yet this area with the flail chest is sucking in. So you have that they call it, what the hell? You have this paradoxical chest wall movement. So the chest is expanding and yet that piece is sucking in. Paradoxical, stop, just stop, just stop, especially Optimum. I'm mad at you these days. That paradoxical chest wall movement is classic flail chest. Again, usually fairly significant respiratory distress, tachypnic, complaining they can't breathe if they're alert, they're tachycardic. You have to really watch their blood pressures because, again, with broken bones, was there penetrating injury to the lungs, the risk of hematoma and blood loss, hemorrhage, if you will, is a concern. The patient who's more alert because of pain is breathing so shallow. I don't think the shallow is a word. In fact, I'm sure it's not a word. But the patient who's alert may be breathing so shallow that you almost don't see any chest wall movement, so it may not be as obvious. But in the unconscious patient, it's usually quite significant. And again, that paradoxical thing is freaky to look at, and you can replay that YouTube if you'd like. Chest x-ray is where we start. That will show signs of the rib fractures. Our assessment or our management is to make sure the airway is intact, make sure they're being adequately ventilated, provide additional oxygen as necessary, IV fluids or pain control. Surgical fixation of the ribs is possible, but not common with flail chest. They often heal on their own, and it's not often that they will try to stabilize the ribs, to be honest with you. A pneumothorax, we talked about this earlier. It's where air enters the pleural cavity and part of a lung becomes deflated, if you will. This impacts the pressure within the pleural cavity. And again, so this extra meaning outside the lung space, has air in it, which is not useful to the functioning area of the lung. It's taking up valuable real estate that doesn't allow the lung to reinflate fully. And so you're clearly creating respiratory issues with this. A big risk from central line placement. Not so much a PICC line, which goes in peripherally, which helps you understand why PICC lines were such a great invention, if you will, because the risk of pneumothorax is negligible with a PICC line. But in the olden days, or even when they're surgically placing a central line, again, one of those short, old-fashioned central lines, they used to do, all you do is feel around for your collarbone, take a needle in, and just sort of drive the needle in until you find the superior vena cava. If you happen to puncture a little lung tissue while you're on your way there, was not uncommon. Chest surgery again, that's a known risk, a known entity as part of chest surgery. Trauma to the chest wall, mechanical ventilation, if your pressures are not right, if patient has underlying lung problems like blebs and things like that, that pop can lead to pneumothorax also. So, and then there's some spontaneous pneumothorax. What's the disease, the diagnosis? Very tall. Think Lincoln have it. Starts with an M. People are very tall. What the heck is it? Anyhow, those folks, because that's essentially a disorder.
Marfan syndrome. Sorry.
Marfan's, that's it. Thank you.
I was just talking about that. Some lady
Yes.
said her husband was 7'3". I was like, did he have Marfan syndrome? She was like, yeah, that's exactly it.
Who were you talking to with that?
A patient yesterday on the floor. She said his arms were really long and that he had heart issues because of it. So here we go.
Yeah, it's essentially a connective tissue disorder, and they're more prone to spontaneous pneumothoraxes. And that's just one diagnosis that I can think of where they're more prone to that. How do you treat a pneumothorax? Well, there are small ones that they will let heal on their own. But in general, we place a chest tube, and the chest tube goes through the chest wall over here on the left-hand side as you're looking, and the tip of it goes into the pleural cavity, and via vacuum suctioning, it reinflates the lung and slowly sucks the excess air out, again, reinflating the lung. And then hopefully the lung will stay inflated. Again, if it's recurrent, they'll do that pleurodesis thing like they did with the pleural effusion. So that's how we treat a pneumothorax. What's that tube connected to? This is by X-ray what a pneumothorax might look like. And here's the lung tissue, which is slightly opaque, and then here's the surrounding air. That's a good sized pneumothorax. So that chest tube gets connected to a suction and a set of 3 bottles, which we'll talk about. So what does a patient with a pneumothorax look like? Well, as it says, starts out here, it's like kind of variable. There are folks who don't feel it or have significant signs or symptoms. So it could be mild tachycardia, shortness of breath. Apparently, of course, the larger the pneumothorax is, probably the more significant the signs and symptoms are. They could have chest pain, pleuritic pain, a cough, may or may not have hemoptysis with it. But on auscultation, you're going to hear grossly decreased breath sounds on the side with the pneumothorax. And again, you can see it on chest X-ray. Again, I said people with folks with lung tissue with blebs, which are common in COPD, chronic pneumonia, things like that, are also at risk for spontaneous pneumothorax. We talked about central line placement being a big risk factor, bronchoscopy, lung biopsies. Again, anytime you're going down into the pleural cavity, there is a potential risk for a pneumothorax as well. So again, chest tubes along with pleurodesis. A tension pneumothorax is obviously a pneumothorax, but it is one that is so significant that literally the trachea and the inflated lung all shift. so that there is this massive shift. Do you remember when we talked about our head-to-toe assessments back in the beginning of January? One of those things that you may or may not do on a regular basis, but I always talk about, is checking for the trachea, making sure it's midline. Because in a patient with a tension pneumothorax, that is one that is so significant. Literally, the trachea can be pulled to one side or the other, causing alteration in the airway and preventing good ventilation through that. Tension pneumothorax is a big deal. It can happen with whether it's an open or a closed pneumothorax. So again, you need to, that tracheal deviation is the biggest symptom that differentiates an everyday pneumothorax from a tension pneumothorax on physical assessment. And then once you do your x-rays, your radiology, you can really see how that whole system gets shifted. And not only do you potentially alter the airway, but you're also potentially shifting the pericardial and all the vessels that are connected in there. This can be a huge, big deal, and not in a good way either. So again, here, you know, you're kind of, there's the trachea gets shifted over, the pericardium moves over, and all of the vasculature there is at risk for movement and occlusion also. So if pneumothorax is air in the lung, hemothorax is blood in the pleural space. And I say in the lung, in the pleural space. Excuse me, I misspoke there. It's in the pleura, not the lung, in the pleura. And again, a hemothorax is blood in the pleural space. Trauma, central line placement again, and chest surgery are two of the most common risks. That would be three most common risk factors for hemothorax. Now, in this case, here's another chest x-ray. Well, again, our lung is obliterated there, but the blood is also obliterating the view on chest x-ray also. And I've said before, I'm not an x-ray reader per se, but nonetheless, here, I like this picture better where you can see it's just blood filling up the extra pleural space, compressing, making the lung volume smaller, which is not good. And a pleural effusion's creating the same effect again, taking up valuable space in the pleura there. Empyema, again, that's that pus in the pleural space. And chest trauma. Somebody comes in with chest trauma and they've got a big wound that no longer has the knife or the penetrating injury into it, whether it was a bullet or they, whoever placed the knife chose to remove the knife and leave the person. You need to cover that wound. And a non-porous dressing. You don't want the air to keep moving in and out. We want to try to sort of stop the air from sucking in through the wound. So you non-porous, something with a plastic backing, something that's not going to let air movement. You still only close it on 3 sides. But you do want to decrease the air coming in and out of that wound. Here's another issue. If somebody comes in with an item that's impaled, again, think knife, think nail, piece of a wooden sled, anything like that, leave it intact. Don't go moving it. Don't try to pull it out. This is not King Arthur and that damn rock. You don't want to pull that that blade out. That's usually done better by the surgical team in controlled circumstances where they can stop bleeding and things like that and clean the wound well after they've removed the item. So that's important when you're down in the emergency department. Never remove an impaled object. So back to chest tubes. Again, this is what we're using to treat our pneumothoraxes, if you will. And I said they get connected to, in the olden days, 3 glass bottles that were connected by a bunch of rubber tubes. Nowadays, we put them into one system called a plurivac. The first bottle is the collection chamber. The second is a water seal, and the third is a suction control. Sometimes you see the water seal first, and then the suction control. Those can vary, but each of these 3 chambers has a purpose that we'll talk about next. So again, once the chest tube is inserted through the chest wall, you don't want the air can get in and out through that chest tube, and that's not the purpose. The purpose is to suck the air or the blood or whatever's in there out of the patient. And the water seal creates a one-way valve. So that's often why that's the first chamber of your plurivac. Once that end tube is in the water, air can't get back in. And when you see bubbles in that chamber, it means air is being sucked out and there is, quote unquote, an air leak. And again, in most cases, that's good because it means the air is being sucked out of the pleura in through the water, creating the bubbles. Again, most cases, that's good. If the chest tube has become dislodged, you may be sucking air out of the environment because it's not far enough into the pleura, into the pneumothorax. But in general, if you're sure the tube is positioned correctly, an air leak is a good thing. And over time, the air leak should lessen because there's less air to suck out, if you will. You do want to always listen, auscultate your patient's lungs. This is also one of the reasons why when you do a chest tube dressing, you surround it with Vaseline gauze and then put another dressing on top of it, because you don't want air leaking in around this tube, and the Vaseline dressing minimizes that effect. Then the second chamber is where stuff gets drained out of, if you will. So if there is a pleural effusion, if there's blood in there, if it's an empyema, this is where it's going to drain into. And that's again, a good thing. We're trying to get that out of the pleural space so the lung can re-expand. And so we're going to physically remove air, blood, fluid, pus, whatever might be in there. And then there's the suction chamber. And the suction is going to essentially help suck the fluid out, suck the air out, help reinflate the lung over time. And those are the 3 chambers of a plurivac. I think I told you this story when I was in Texas. Was with a cardiothoracic surgeon. He was on the older side. He was probably late 60s, early 70s, big, tall guy. He used to wear a cowboy hat and his 6 shooters when he did rounds. I didn't realize he carried guns when he came into the hospital until I was meeting with him. It was supposed to be 2-on-1, I was a consultant, and so I was supposed to meet with this physician and my physician partner, who texted me that morning that his flight was late, but I could go ahead with the meeting on my own. So there I am meeting with this guy, about 6'4", plus his cowboy hat, wearing guns. And I need to tell him that it's, for the love of God, it's 2010. You can't use glass bottles for your chest tubes anymore. It's no longer the standard of care. He was a very nice guy. He just didn't trust those newfangled Plurivacs, which we're talking newfangled. We're talking the 70s here. We're not talking, I don't consider something developed in the 1970s as truly newfangled, right? I mean, I think in 40 years, that's pretty tried and true. But again, pre-1970 glass bottles, post-1970, a little plastic box. Has anybody cared for anybody with chest tubes yet? Does anybody know one of
I
them?
did at UConn, but that was only like one day.
Oh, well, who needs more? There you go. You're an expert now, right?
Well, they had me look up the stuff that it's cool that UConn Health has like a whole section dedicated to their specific teaching. Like
Yeah.
they'll take things from other sources and like narrow it down to like what they want specifically for their nurses and their clinicians. And I just thought that was really cool. So I looked that up for my preceptor for chest drainage tubes.
That's excellent. Very good. So one of the things that you need to about chest tubes is, unless you are getting ready to remove them, and even then in most cases they don't, you never clamp them. You never want to close off that flow. And so that's probably one of the most important things to remember about chest tubes. So don't clamp them, don't get the tube kinked so that suction and or air isn't moving through. But chest tubes are a significant intervention. And while they do many good things, they need to be assessed regularly to make sure they're doing what we hope they're doing. And we need to prevent complications. So again, you need to make sure you're doing your respiratory assessments on a regular basis. And they need to breathe deeply. You need to auscultate their lungs. You need to make sure you hear breath sounds. They can ambulate with their chest tubes. The new systems, that medulla that I spoke of earlier, that's smaller than a little purse. It goes on battery, so they can walk the whole unit as needed. Even with a chest tube and a Plurivac, they will often set that suction up on an incredibly long, so the patient can walk all the way into the room, get to the bathroom, walk outside their room, because ambulation is really important. And then once a patient, you're getting ready to remove the chest tube, they go on a water seal trial, meaning they're disconnected from suction. Does the lung stay inflated? Does the patient feel well? Is there increased respiratory distress? So again, eventually the chest tube needs to come out, and we need to plan for it, and we need to keep the patient safe in the meantime. Again, you just don't clamp a chest tube. Just don't do it. Important thing to remember. When we put a patient on water seal, that means we're disconnecting him from the wall suction. It's not just turning off the suction. You literally want to disconnect it. I don't wholly understand why that's different, but believe me, people that work with chest tubes all the time, are they disconnected? That's what they'll ask. So a patient comes back to the unit after thoracic surgery with a water-sealed chest drainage system. What should the nurse instruct the patient and the family about the main purpose of this system? Is it A, to remove excess carbon dioxide for the blood, monitor the quantity of pleural fluid to enhance the patient's expiratory drive or re-expand the lung and remove excess air and fluid?
D. Delta.
Delta, thank you. Don't you wish I gave these easy questions on the quizzes?
Yes.
All right, kids. That's all I have in terms of formal presentation, but because I am running a little ahead of schedule, I'd like to do case study with the group today. I really tried to not condense the lecture, but be more timely about my lecture so that we would have time for a case study and that sort of discussion thing, if you will. So I'm not going to say, I was going to say bear with me, but that's not really the right word. Play with me so that we can all learn. How's that sound? Cancel. Wrong thing. Wrong button. Wrong button. All right. Does everybody see pleural effusion case study now?
Yep.
Yes.
Excellent. I'm kind of getting, well, I shouldn't say that, should I? All right. So what's the word? So Mr. B, 68-year-old gentleman comes to your floor. He's got a diagnosis of a pleural effusion. He complains of shortness of breath, pain in his chest, weakness, a dry, irritating cough. Vital signs are blood pressure 142/82, heart rate of 118, respirations 38, labored and shallow. His temp is up to 102.1 or 38.9 for your centigrade folks. His O2 sat is 85%. Chest x-ray reveals a large pleural effusion with pulmonary infiltrates in the right lower lobe consistent with pneumonia. And you're on your medical floor and you get this patient and you're like, cannot believe they transported this dude with a O2 sat of 85%. The hell were they thinking? But I digress. Given his diagnosis, what do you think about his admission vital signs? What are the factors that are influencing his vital signs?
His pneumonia and his pleural effusion.
And what are the direct effects of those, Kevin?
So the pleural effusion would prevent his lungs from fully expanding, so he can't get as much, his lungs don't expand as much, and it would hurt to breathe. So probably that's why it's more shallow. And his pneumonia would give him a temperature because it's infection. And that would also affect his O2 sats because pneumonia, it's in his lower right lobe. So
Very good.
and respirations would just be higher because he's trying to compensate for the lower labored and shallow breathing.
Good. Very good. So why is his heart, and Kevin, you did a great job. We're going to get somebody else to jump in now. Why is his heart rate elevated? What are some of the reasons his heart rate is elevated?
His respirations and his SpO2.
So what's the heart trying to do
Pump
there?
oxygen to as many places as it can very hardly.
Yeah. Anything else in that scenario that might have increased heart rate?
Fever.
Fever. Yep.
Would it also be because of the pleural effusion? There's not as much space to fill up, so they tend to breathe faster since they're not filling up as much.
So they're going to try to turn it over faster, if you will, Linda. Is that kind of what
Yeah.
you're saying? Yeah. I think that's
Also, like anxiety from not being able to get in enough air will increase your heart rate as well.
and your respiratory rate. That's as we say, that's a good way to get the blood moving. Anxiety, pain. And again, that response to an inflammation just increases your metabolic rate, which again increases your respiratory rate, increases your heart rate, etc. Nice job. And so now talking about his the pathophysiology. Again, explain, what's a pleural effusion?
It's liquid in his pleural space.
Good.
Caroline, a quick question. The vital sign for the blood pressure,
Yeah.
is it because of the pressure being put onto the cardiac system, the heart? Or is that separate?
Well, I hesitate to say it's separate, James, because you can rarely separate the respiratory tract from the cardiac tract, you know. But hold on one second. I just lost my train of thought. But the increased blood pressure is also a bit of a way to make sure the blood is perfusing as effective as much as possible. Okay.
So that's compensatory action then by the body?
Yes.
Okay.
Again, he we don't know, he may be hypertensive otherwise, but that's even if he wasn't, that would be in keeping with his presenting symptoms. All right, so James, you said that, so the pleural effusion is that fluid building up in the pleural space. And do you remember I said that there are two kinds of fluid in a pleural effusion?
Blood being one.
No, I didn't say blood.
Pus.
Transudate and exudate. Again, that often, once they tap the fluid, they can have a better explanation of the source. And again, when you have, whether it's air or fluid or blood building up in the pleural space, how does that compromise respiration? Kevin, you said it earlier. What did you say?
It would cause pain and also prevent the lungs from fully expanding.
Yep. Again, valuable real estate is being taken up and lungs cannot expand, therefore putting additional pressure on the remaining lung tissue. And another thing we didn't talk about, but the pleural cavity actually is highly sensitive from a sensation perspective. So it's very sensitive to pain triggers and things like that. So again, while not everybody recognizes it, it's not unusual to have significant pain with a pleural effusion. Just as an aside, if you will. All right, good job. So moving on, we perform a thoracentesis and they take out 1,500 milliliters of fluid. A specimen sent for culture and sensitivity. They start him on antibiotics of Ceftin, 1 gram IV every 8 hours. And again, what's the purpose of the thoracentesis?
Drain air or fluid.
Yep. And again, you can do repeated thoracentesis, or once they have more information, they may put a catheter in to stay so that you don't have to needle stick the patient each time. Right. Let's do this med math question, and then I want you to put your answer into chat. So don't call it out. So your Ceftin is 1 gram in 100 milliliters over 30 minutes, your IV tubing is 20 drops per milliliter. How many drops per minute? Thank you, Jimmy C. Okay. All right, everybody's agreeing. All right, Mr. Kincannon, you led the crew. They're happy with your answer. Thank you. All right. So what are we going to do after the thoracentesis is done? We've got our patient, trying to get him settled and comfortable. What's one of the most important things we can do for this patient from a respiratory perspective? Yes, you're going to do your assessments, but how are we going to clear his secretions and hopefully improve his respiratory status?
Sit him upright.
And what's sitting upright help facilitate, Linda?
It helps facilitate easier breathing and clearing of secretions where you're not can't think of the word right now.
Welcome to my world. Expand the lungs.
Yeah.
Wasn't the word you were looking for? Expectorate.
Yes, that would be it. But yes, to expand the lungs easier.
Okay. So, and besides sitting upright, what do we always encourage patients to do respiratory wise?
Use the incentive spirometer.
Use the incentive spirometer. Again, that deep breathing. Very good. Okay, so the CNS report comes back. And he's got Klebsiella, and it's not sensitive to the cefuroxime or the Ceftin. So again, while we are not often part of these decisions, if you were in a smaller hospital, what would you do? What would you expect to happen, is another way to put it.
Stop the Ceftin and switch to an appropriate antibiotic.
There you go. You're not going to keep giving Ceftin if it's not shown to be effective. You need a different antibiotic order. Exactly. So we need to advocate for our patient. Now the fluid is recollecting in the pleural space, and they're going to insert a chest tube. And so how are you going to work with the patient in this case? How are you going to get ready for this procedure? So first thing, you're going to help collect the equipment needed. So it's called the thoracotomy tray. You need chest tubes themselves. Make sure there are sterile gloves and towels around. You're going to ask, what do you want for analgesia? Do you want to give an anti-anxiety? Do you want some sort of pain med? What kind of lidocaine do you want? If they're inserting a chest tube, what else do they need? We just talked about a chest tube. Is a chest tube a standalone intervention? What else do you need? The drainage system. So whether it's a Plurivac or whatever system they're using, need to make sure your suction is working. You need dressing supplies. What did I say you need for a dressing for a chest tube? Is this case not scintillating enough? Are you already studying for research? Do you want me to stop here and just let you guys go and get ready? You can say yes. Because if we're not going to review this case in sort of a give and take way, I'm not sure what the benefit of it was or is. Have you all signed off? Am I alone in this one?
I mean, I'm sure a lot of people want to study for research. I think this is helpful, especially because we're going to need it next week. And it's good to apply it.
Okay. All right. So just
I
give
just
me a
didn't have
little.
the answer.
Give me a little something. I mean, even if you don't know, just say, it's okay to say, I have no freaking clue. Give me a hint.
Oh.
I'll try. But
Yeah, I wasn't saying anything because I have no clue. Crickets in my brain right now.
I appreciate that. You guys, you know me. I understand. We don't need to be on all the time, but just let me make sure you're there, sort of thing. So if you're going to get ready for chest tube insertion on the floor, you need to have your Plurivac setup or whatever it's going to be connected to. You want to make sure your suction works. It would be awful to find out the suction doesn't work after the fact. That would be me, of course.
Were you looking for the Vaseline gauze?
I was looking for the Vaseline gauze. Yep, got it. That's got to be wrapped around the chest tube to prevent that air coming in and out, and to prevent subcutaneous emphysema from forming as well. And after the chest tube is in, again, it's a little weird when something's connected to you. But again, remember that these patients can get up and walk if mobilization is if he's not a fall. Again, you have to put in all the safety issues in terms of fall risk. But don't think a chest tube means bed rest only. Not at all. These patients should be helped to get up and to get mobilized. Okay. And then what's your assessments look like after the chest tube is placed? What's a basic respiratory assessment look like?
Well, you want to check his O2 sats.
You want to check your SATs?
You want
And
to check
if you're
Rate, rhythm.
What was that? I'm sorry.
Rate, rhythm, and like work of breathing.
Correct.
Look for paradoxical chest movements.
Yeah, that's with the flail chest. You don't see those a lot. But what else is core to your respiratory assessment?
Also take lung sounds.
Auscultate lung sounds, absolutely. And in this case, the point is to re-expand the lungs. So with the effusion, remember you might have had decreased or distant breath sounds. If you've effectively re-expanded them, you should have better breath sounds in all fields. So a before chest tube and post chest tube could be interesting. If it's effective, you should literally hear the difference. Chest tube's been placed. Again, it's got centimeter marks on it so that you know it hasn't moved. Document where it is when it's initially placed, and then check to make sure it hasn't moved. You want to make sure if there's any drainage, you mark the drainage on your Plurivac system every, at least every shift, if not every couple of hours, depending on the volume, so that you can note how often that's happening. You want to make sure that the suction is the right level. You want to make sure that the water seal is effective.
Would you mind just going over that briefly one more time?
That list or water seal?
Water seal.
Sure. So you put the chest tube in, and essentially all you've done with the chest tube is created, if you will, a bigger hole for stuff to come from the outside in. It's not until you hook it up to the suction that you're starting to close that system so that you can suck the extra air/fluid out and re-expand the lung. By putting that end of the chest tube into a water seal, it creates a one-way valve so that it only comes out with the suction and can't be sucked back in. Does that help, Linda?
Yes, very much. Thank you.
No problem.
And then the second collection chamber to separate out the fluid, is that just because you want to know exactly how much fluid you're getting out?
Exactly. And again, with a hemothorax or pleural effusion, how much are they losing? And the hemothorax, I mean, if the pleural effusion is important also, is it recollecting? Is it, what do we need to do here? Is chest tube helping? But particularly with a hemothorax, are they continuing to hemorrhage? Is that blood continuing to be sort of bright red, freshy blood? You want it to slow down, whether it's after surgery or because of a trauma. You don't want them to continue bleeding. So we want that drainage to decrease over time. Does that make sense?
Yes, it does. Thanks.
Okay. All right. So the water in the suction control mechanism limits. Okay. All right. So here's a question. Chest tube, true or false? So look at each statement and say whether it's true or false. And if it's false, why is it false? So the first one is the height of the water in the suction control mechanism limits the amount of suction transmitted to the pleural cavity.
I think that's true.
That is true. That's a hard one because we didn't talk about it. So you set the, and that's why you sort of want a gentle bubbling. You don't want ferocious suction. You want a gentle suction. And even though you've got that suction on, it's still sort of being mitigated through that water so that it's not a direct hard pull. This one I'm also going to sort of give you is a suction pressure of 20 centimeters of water is usually recommended for adults. And actually, it's actually negative pressure. So it's sucking it out. Positive pressure would push it in. Negative pressure sucks it out. So that was kind of a trick question, if you will. To me, suction, I guess, the fact that it said, I had to look at that one 100 times because it says suction. To me, that's negative, but they just want to make sure you know that it is a negative pressure sucking it out. Bubbling in the water seal chamber usually means that air is leaking out of the lungs, the tubing or the insertion site, and is usually a good thing.
True.
True.
That is true. Again, so long as the tube's placed correctly and you've got the right dressing, that should be true. Number 4, the rise and fall of the water level with the patient's respirations reflect normal changes in the pleural cavity with respirations.
I think that's false.
Actually, no, that's
True.
true. Again, you have altering pressures in the pleural cavity with inspiration versus expiration. And that rise and fall of the water just shows that normal alteration, James. Again, I know we didn't talk about it and all, but just to make sure you know that that is normal. All right, because the chamber is a closed system, water cannot evaporate from the system.
True.
It's actually, it is false. It's actually not a closed system. There is evaporation, and you can add sterile water or normal saline, depending on your facility's policy, to the chambers, done in a sterile method. So again, you need to check on that water level also. To declot
Is
the
this on a new
drain.
page, Carol Ann?
What? Oh, thank
Is this
you.
on-
Yep, yep,
Thanks.
yep. All right. Thank you. Number 6, to declot the draining tube, compress the tubing and strip the segment to try to move clots along.
Is that false?
That is false. And why do you think that is?
Because you don't want to compress the tubing.
Never clamp or decompress the tubing. That is absolutely correct. Thank you. Good job. Number 7, you lower the bed on top of the drainage system and break it. Doesn't that sound like something I would do? You immediately clamp the chest tube, leaving it clamped until you can reestablish the drainage system. What did we just say in the previous question?
False. You never want to clamp the chest tube.
Yeah, as big a disaster as that may be, no, leave it for a moment, get your new, or stay with your patient to make sure they don't have a compromise, call the cavalry, ask them to get you a new Pleurovac and some sterile water and get it reset up.
So the last one's also no, because you want to, it's saying clamp it again.
Exactly right, Kevin. Yeah, and again, you can disconnect it. In this case, because the collection chamber is full and you need a new one, be planful about it. Don't disconnect it, then run and get your new Pleurovac. Bring your Pleurovac in, have all your supplies necessary, and then disconnect and reconnect in a more coordinated fashion, for sure. All right. You come back again the next day, you're still working with Mr. B. At the beginning of the shift, you find his condition is stable. His lung sounds are diminished in the right lower lobe. Again, he's got a pneumonia, so that could be an issue also. But he's O2 sats at 95% on 2 liters of nasal cannula. The chest tube drainage systems connected to suction at negative 20 millimeters of mercury. There is still an air leak present. His his morning chest x-ray examination showed residual pleural effusion. 4 hours into your shift, he pages you and tells you he feels short of breath. He's sitting in his chair. What sort of assessment are you going to do now?
Look at the tubing, see if there's a plug.
Good job. Look at the patency of the chest tube. What else?
Listen to his lung sounds again.
Auscultate his lung sounds.
Check the machine, see if it's still pointing at negative 20.
Okay.
Get an O2 sat.
O2 sat, and what else?
Respiratory rate, work of breathing.
Can we just go with vital signs?
Yeah.
Yeah, let's just do all 5 of them, okay? There we go. And you probably also want to look at the insertion site. So you've checked the tubing to make sure it's not clogged. You've checked his suction. You see that the box is intact. Let's go up to the insertion site to make sure it's still at the right level, the dressing's intact. So you have new subcutaneous emphysema, things like that. Okay? All right. And so he is resolved. He's feeling better. Do you think, this says here, write an example of documentation. Is this an event that would need to be documented, do you think?
Yeah.
Yeah.
Yep. And again, you want to document all the findings of your assessment and whatever interventions you used to help him feel better. So it never really talks about what happened there, but luckily it resolves. So his admission, the rest of his admission is uneventful. He's got 6 days of aggressive antibiotic and pulmonary therapy. They discontinued the chest tube. He's ready to be discharged. So what are some of the things you're going to include in your discharge instructions to him? And let's assume he's going home.
Make sure he takes the full course of his antibiotics.
Finishes his course of antibiotics, absolutely.
Signs and symptoms of when he needs to seek medical attention.
Signs and symptoms of when to seek medical attention, and what sort of things do you want to highlight in that?
Like trouble breathing, feeling short of breath, dizzy, coughing.
Yeah, very good.
Fever.
What to look for at the site. Sorry. What to look for at the incision site as far as infection.
Very good. And so he may have a bandage over that for some period of time if the, again, somebody cut into his chest wall. So he'll have a bandage on it for some period of time. And other signs, and not only infection at the site, but how about signs of a systemic infection as well, which might include what?
Fever, diaphoretic, nausea, vomiting.
How about at the site, what's he going to look for?
Swelling, redness, drainage.
Beautiful, very good. Now, Kevin, you spoke to finishing the course of antibiotics. If he's sent home on any other medications, take them as prescribed, right?
Yeah, as long as there's nothing contraindicating that why you should stop taking it for any reason.
Right, and if he believes there's a problem with a medication, what would you recommend he do?
He should contact his doctor.
Yep. And how about activity? Anything we want to mention about activity?
restrain from any strenuous exercise for X amount of days.
Well, you're right. He probably shouldn't be lifting and pulling until that wound is healed. I certainly agree with that.
Also, in terms of showering, I don't know what the precautions would be for that incision site in terms of showering or bathing.
Yep, that's a good question. And to be honest with you, at this moment, I'm not sure either. I will have to look that up. But that might be a concern also. But do you think this is a patient who, and again, 68, getting younger every day in my book, but if he's been in the hospital for 6 days, and as much as we've encouraged him to walk as much as he can while tethered with a chest tube, do you think he might benefit from some physical therapy? So hopefully we'll advocate, or at least have a physical therapy assessment before he leaves to see if that would be helpful for him. If they determine he does not need physical therapy, then let's encourage him to walk regularly, to not be a chair or a couch potato. That walking will help him. And if he does qualify for home physical therapy, let's make sure that referral is made also, right? And then we can talk about how the walking improves and helps his respiratory status. All right. I will post the answers to the case study in case you had any questions. Any other questions I can help you with now? Why doesn't somebody explain what's going to happen with the quiz tomorrow so that we all know?
12 noon to 4 Saturday.
Right.
At 4.
Yep. So you got to be done. And
Done by
how
4.
long do you have to complete the quiz?
25 minutes.
25 minutes.
Right. So I don't want you to think you're going to open at 12 noon on Friday and meander your way through it until 4 p.m. on Saturday. Still have 25 minutes. And again, counting on you guys to be the professional with great integrity, and take this as if it was any other quiz, please. I'm here for questions. I will send you a blueprint for next week's quiz. Does anybody have any questions on either today's lecture or tomorrow's quiz topics they'd like me to address now? Hearing no questions, I'm going to bid you all a fond adieu. I'm going to wish you well this afternoon. I'm going to go light a candle for everybody.
I have a quick question just about, okay, so they did that virtual career fair, and then most of the people who were assigned to Yale were in clinical, and I know you had mentioned that. So is there any way for those of us that were in clinical to be able to get in touch with those people, or should we just talk to people on our floors if we're potentially interested in working there, or what?
So,
Kristen,
because you're connected.
Yeah, well, whether it's Yale or any other
I'll
hospital.
let you know, because
Yeah. I was thinking Yale because I knew that they went to it. And
so Kristen, originally there was supposed to be a certain set of people that came from Yale to do us like a presentation of sorts, and they fell through in a sense. So they sent like a sourcer who pretty much like you send her your resume, whatever, and like she sends it up to whomever when it comes time for that. So she just gave like a very brief, if you're interested in Yale, like try to figure out what area of Yale, and if you're interested in which hospital from Yale. But she really didn't say much of anything. She said there's going to be 2 more like reviews or meetings and career fairs coming up in the next 2 months. So like by the end of November, there should be 2 of them. And she said those are really going to be the bigger ones that are actually going to impact us because there's going to be actual people from Yale at those.
Yeah, they didn't say anything like what departments are particularly looking for people or anything like that.
She's not anything at
It
all.
was just like,
She just
here's
said,
somebody
if you
from
attend
HR.
session,
So
she'll send the
you
information out, and she said make sure you attend those.
so in general, by now you should open accounts at the hospitals you're interested in and see what sort of positions they're posting. The way Yale New Haven works is they hire like a medical cohort, a surgical cohort, pediatrics, and on their website, yes, you will apply. Yes, you'll talk to them at the career fair. Those are very valuable interactions. Don't misunderstand me. But whether you've participated in a career fair or not, when you see those positions open up on unit you're interested in, apply for them. Send your resume to that position. Put a formal application in. And there's definitely a career fair on November 5th that Yale has traditionally attended, and we're trying very hard to get them to come to one of our classes here on a Thursday morning. I think that's a valuable way to spend time, because again, it's not just it's really all the hospitals of the system. But again, start looking at the hospital websites to see what positions they're posting. And share that information with your peers who you know are interested also. Okay? Does that help?
And so do you think it's most valuable? Yeah, it does. But do you think it's most valuable for us, like starting off, to go just look at hospitals? Because obviously hospital nursing isn't the only kind of nursing.
Oh yeah, whatever agency you think you want to work for, start looking at them. And there are home care agencies that take new grads. Some of the FQHCs now are taking new grads. So there's a lot.
What's an FQHC? Sorry.
Federally Qualified Health Center. That would be the Hill Health, the Fair Havens, the
So it's like a long-term care?
No, outpatient primary specialty care.
Oh, okay.
The long-term care facilities will definitely take new graduates also, if that's what you're interested in. Absolutely.
No, I wasn't sure about the
okay. No,
acronym.
I'm sorry. It's underserved primary.
So it's like a community health center.
Community health center. There you go. Thank you. Yep.
Okay.
Thank you. Yep.
Caroline, I have a question. Do you think it's easier, since we're UConn students, would you say it's easier to get into, or like you have priority to get into UConn Health, or it's not related at all to the?
I don't think it's related at all.
Oh, I found out a really cool thing about UConn, if anybody wants to know, but I think if I personally want to work for them, I'll probably wait. I found out that nurses, if you have children, depending on the amount of time you are a nurse, not like length of time, but like basically the way they do their weekly time is you're either considered, like, most of them are, it's like a 0.9 nurse, which would be like your 312s. Some people have like their 40-hour weeks. That's how much percentage you could get free for UConn for you or your children, not partners though, just you or your children.
Oh, so tuition, even at the health center? Nice.
Yeah.
I did not know that. Now UConn is.
But they don't have my specialty for grad school. Nah.
UConn Health is Union Hospital, Norwalk, Danbury or Union, Waterbury, Union.
But there
Not
are
that it
different
doesn't
unions
really make
too.
a difference, don't misunderstand me, but it's just one of those things that goes into the pot, if you will.
And I guess if you work at Yale, not the hospital, but for the health service, you can get the same thing, but you have to work there for like 5 or 6 years. But for some of the younger students in this program, that might be of value.
Yep. And again, Yale University Health Center they do have a small inpatient concern, but it's predominantly outpatient.
And for the community health centers, if folks want to work there, like you can look into like the federal grants for student loan
Forgiveness.
forgiveness. Yep.
Yep. Yeah, I speak to the hospitals only because that's what I'm most familiar with, and that's what most students are looking for. But don't ever be discouraged if that environment is not what you're looking for. There are lots of options, and
I just want to know what your opinion was. Like my APRN who mentors me too, she told me, because she's worked in a bunch of places around Connecticut, like over the last 30 years or whatever. And she told me not to go up here. I wasn't going to right away anyway, to any of like the smaller hospitals up by us, like, you know, Charlotte or Sharon or anything. She told me, she was like, I think you should go first and do a big hospital and get more experience right in the beginning.
you know,
more broad experience and more depth of experience.
Yeah, you know, and yet I had a student a few years ago who started at Sharon. He wasn't looking to be an acute care nurse practitioner or stay in acute care for a prolonged period of time, but he got his experience. He's in graduates, actually he's graduated from graduate school, and he's doing his primary care thing. And I think it depends. If you want to be an acute care nurse practitioner, you know, probably that's not the right path. But if you just want experience and primary care, whatever specialty it may be, is more your target, then I'm not sure whether that's as hard and fast. If you want to work with kids, you kind of got 2.5 options in Connecticut.
That was the other thing I was balancing out, because I know, like, I was thinking a while ago, I was like, well, when you're in grad school and you're working a little to make money, you might want to be at a slower place because maybe you'll have a little, you know, I know you never really do, but you might have a little downtime to be able to study if you're at like a smaller hospital. So I was like,
you know, I don't know if that really works out. Personally, I think the best, if you're in graduate school, I worked in the ED when I decided to go back to graduate school, and that was, to me, perfect. So graduate school or outpatient clinic, something that when your shift is over, it's over. You don't need to think about coming back and facing that patient tomorrow or seeing them again or planning for the, noodling that care plan around in your head, thinking about the family. When your shift is over, your shift is, I don't mind, if they're paying me to work, I don't mind working that 8 or 12 hours, whatever it is. I'll give them my all. But when it's done, it's got to be done. So whether it's anything that's truly in and out shift based, that's what I recommend for graduate school. But I'm not sure there's much downtime anywhere in this world anymore, but could be me.
thank you for the input.
All right, so again, guys, I'm going to stop the recording now. You know how to find me. Don't hesitate. Ask me questions. I'll get that blueprint out as soon as possible. I will get the password out tomorrow, 12 noon, and I'll see you soon, okay? Bye, guys. Thank you.